It's inspired after I heard that Professor Clark is coming to India to deliver his lecture in Sogocon in Hyderabad. So we conceived an idea that we hijack him from Hyderabad to Chennai so that it'll be inspirational for the next generation, of course, for us as well. But in addition to that, the next generation. Many of us know about Professor Clark. He needs no introduction, but a word or two about him is that when I started my training in 2000, Professor Clark was in Christie Hospital, and I was a trainee in Manchester region in Preston. And the Northwest Regional Audit was a place where we used to go. And that was my first exposure to quality research, where we used to present our audits or simple projects, and it used to be critiqued in a very nice way, which will be, in a way of elevating the project up. And then I realized that critical thinking is a crucial aspect for medicine to progress. If we don't do critical thinking, then most of us will end up being technical surgeons. And the critical thinking is the one which, sets us apart to become doctors of use to the society. And from that point onwards, I did MD and then subsequently consultant job and then moved here. And we have seen Professor Clark's presentations in Stampede trial. And when I was a consultant with me and Sanjay were working together in Bradford, Professor Clark came more than once to mentor us for neobladders, especially female neobladders, because both of us were new and we were dabbling with it. And he was very kind enough to come a couple of occasions to mentor us as well. He has never said no whenever we ask help. Of course, not in the middle of the night, but elsewhere at any point of time. You ask him a simple question. The answers is profound and simple. Sometimes you think, oh my God, why didn't I think that way? So these are things, as new consultants in Bradford, we have troubled him more than once, many times, to ask for help and guidance. For me, bringing him to Chennai was a very elating moment, and I want to share that moment with all of you. Thank you so much, Professor. And on this day, I thought it was also very important to, have my friends here, Anant and Madhav, being part of this meeting as well, to present some data on the things that are changing in the world now. Proteus is a very important change that has happened. Good or bad is a debate, but it has happened. And for once, there is evidence, and the evidence can be discussed, but it is there. So it is time to hear that as well. On my call, it is so amazing and humbling to see many seniors, my teachers, my professors, who have assembled even before my PG students. That is just amazing at the commitment that that generation has on, continuing medical education. And I wish the next generation has the same as well. With those words, I'm going to play a video by Sanjay, because it will be only apt that Sanjay's video be played about Professor Clark. Video is on, yeah. You need a audio or something like that? Audio pin? Yeah, please. It started now? Okay, I'll just put it in the groups as well. Yeah.
Everyone who have assembled to listen to. Good evening, Raghu, for this opportunity to introduce Professor Clark on the second occasion in 2 days, which is always a pleasure. And good evening, everyone who have assembled to listen to one of the icons, one of the newsmakers, as well as influencers in uro-oncology. For you, it's a once in a lifetime opportunity. I can assure you of that. My association with Professor Noel Clark almost is now more than 25 years, and I say that I'm a much better human being, much well-rounded human being, leaving everything else. That's what he has taught me. It has been 25 years of training, guidance, mentoring, and more than anything, inspiring you to do something different, inspiring you to find the difference that would make a difference to the other people. And he continues to do that. And that's what he has done for more than now 35 years of his professional life. What have been the standout qualities that I try to practice day to day is the first one is ensuring quality. I gave one example yesterday of how when I first started with him about doing urology. I'll just give you another example. Like whatever surgery, I worked for 2.5 years as a surgical trainee with him, any major surgery, you know that for positioning, no block will be there. The reason is whatever the seniority you have, if you were not there for the initial positioning of a partial nephrectomy or any sort of thoracoabdominal incision for a large kidney, you do not have a right to moan about it. And he taught that by being there. Every time a patient was being positioned, you know that he will drop it and make sure that there is that minor correction that needs to be there. And that was his way of ensuring that quality is not guaranteed, it needs to be guaranteed. It needs to be maintained by having certain level of checks so that you deliver quality all the time. The second one is hard work. Hard work cannot be intermittent, hard work cannot be optional, hard work cannot be episodic. Every day, whenever you want to meet Noel Clark, be there at 7 o'clock in his office, he will be there. And that is for all quarter of century that I know. If you ever wanted to meet Noel Clark, go on a Saturday morning at 7 o'clock, he will be there in his office. To maintain that sort of consistency with respect to putting in the effort, it needs a special kind of effort, it needs a special kind of drive, and special kind of a commitment towards the cause that he shows by example. The third is making a difference, which has been the driving principle trying to make a difference, and that is in my body's that by doing so much, any trial you take of Stanley trial, radicals, propel, these are groundbreaking is an understatement. These are earth-shattering sort of studies which have influenced every urologist, every prostate cancer patient across the globe. Whether they know who are the people who have done these studies, but they know the outcomes. They have affected lifespans, they have affected the way everybody thinks about treating prostate cancer. And now with this new design techniques, it's influencing other solid organs. The best thing about Professor Clark is that whenever I go into the people ask me what kind of a leader are you, or I ask that question, what kind of a leader are you? And then I ask myself the question, what kind of a leader am I? And why am I that kind of a leader? Answering the second question first. Big leaders, big people who have actually truly influenced you, they don't need to tell you anything. They are setting an example, and by setting an example at such a high standard, they expect that provides enough of an inspiration for the younger generation, if I can call myself that, to follow in their footsteps. And he has continued to do it. When I was appointed as a consultant, when I needed help, when I was appointed as a consultant because doing research and when I started a job in India, every time there was always a new hand from Noel Clark. So, whatever I have turned out to be, whether it's good, majority of the time, all the good things that I have done in my professional life and what I try to do towards my training has been guided, has been inspired, has been taught by Professor Clark. It's an absolute pleasure, and I can assure you this, you are in for a proper thrilling ride of managing prostate cancer that will make you think in a different way of managing a prostate cancer next time you see one. Thank you. Enjoy the talk.
Thank you so much. Those are very true words. I mean, I have had the opportunity to be with Professor Clark, and what Sanjay said, every word of it is true. With those words, I'm going to invite Professor Clark to start the first talk, after which the next will be Anand's. So, and this opportunity, I want to take a special thanks to all the seniors, the professors who have come and been here. Thank you so much.
Yeah, we're in control. Well, firstly, I'm very humbled by that those words from Sanjay and from Raghu. It's a great pleasure to be here. I've always kind of felt a sense of imposter syndrome dealing with the kind of things that we deal with. And I think it's also important to emphasize that this is not a one-person sport. It's a team sport. And one has to build a team of hardworking, talented consultants, specialist nurses, anaesthetists, pathologists, radiologists, and that takes time, but the rewards that produces are considerable. And one of the great rewards is to see fellows like Sanjay come through and make a real difference in India. And we've had fellows around the world, I'll show you some of them, and we put them in many of the academic and business departments around the UK. So I'm going to give two talks. One is a slightly technical talk about the landscape of precision medicine in prostate cancer today. Now, this is a very big topic, so I'm going to slim it down a little bit. I do have conflicts, largely through academic trials like Stampede, Propel, the PAX trial. And I'm the joint clinical lead for the National Prostate Cancer Audit and have been since 2013. And we collect data on every patient diagnosed with prostate cancer and all the details associated with that, what their grade, stage, treatment and outcomes are. So just to give you a flavour, the population of Great Britain is expanding. It's way, way short of India, but nonetheless it is getting bigger. And we have about 50 to 60,000 cases, new cases a year. And that's going up and up and up. And we have to adapt to that. But whilst adapting to this, we have to keep our feet on the ground and understand that what we read in the academic trials and in some of those case reports and meta-analyses does not apply to certain elements of the population. And it's important also to remember the very basics in medicine. I come to this in my second talk, which I hope you'll find stimulating. Very straightforward things. The patient's performance status, comorbidity, age, ethnicity, simple blood tests. So many of our trainees now, I have to ask them, what's the alkaline phosphatase? They don't know. So I said, well, here's why you should know, and take them through that kind of stuff. Many of the patients have had prior treatments and have comorbidities, heart disease, lung disease, abdominal operations, and so on. And then we have some of the advanced level markers, which have been associated with identifying cases which don't necessarily need intervention and substratifying those for patients that do need intervention. Now, this schematic was put together by Craig Jones. Craig is now a consultant in Manchester. He was one of our research fellows, very bright. And we have a number of categories that the patients fall into. So we've got localized disease here, non-metastatic castrate-resistant prostate cancer, metastatic hormone-sensitive prostate cancer, where there's been a sea change in how things are managed, and metastatic castrate-resistant disease. And for those more senior members of the urological fraternity, will remember that once the patient who presented with metastatic disease had ADT at this point and then failed, there really wasn't a great deal else available for them. For the purposes of this evening, I'm going to focus on this area for the first bit. And this is localized prostate cancer and how to manage it. And what I'm not going to do is talk much about active surveillance and the treatment of low to low intermediate risk disease, although I will explore some of the recent publications about focal therapy further on in my talk. So I'm going to go through the relevant factors. So for a start, what are the clinically relevant factors diagnosing and managing prostate cancer in 2025 when I put the slide together, and now we've moved on to 2026. And the reason I've got 2025 in here is because we have data from the National Prostate Cancer Audit. We can see what is incident. And when you think about the Gleason scoring, which is one of the better predictors of outcome, and this in this column, you're looking at Gleason's 7 and 8. You can see that about just over half of the patients have got Gleason 7, and about just over a quarter have got Gleason 8 or above. And then when you look at some of the other data, the high-risk area, which is where we're talking about, you've got over a third, 37%, who've got clinical T3 disease, and we have about 11% who've got metastatic disease. Now, that's very different to the population incidence in India, and that's been very clear to me in various visits and reinforced today. So we've got problems in working out exactly what to do with these patients, because what we know is that a significant proportion of the men presenting in this space here and in this space here, this is M0, they're quite elderly, and they're comorbid, and they're socially deprived. And they may not be the kind of patients that get into some of the frontline trials that we all read about, and in some of the case series reported from some of the big centres in Europe, in the US, Canada, Australia, and elsewhere. So let me just step into this space here, which is the interpretation of the histology. Now, when we were reorganizing cancer in England, which we did in between 2000 and 2005, this is GU cancer, we expressed a view, David Neal and I, who were doing this, that the ordinary urologist could often read a scan, CT scan or an X-ray or even an MR scan. But an ordinary urologist could not interpret a pathology slide. We were completely dependent on the pathologists. And we know that the inter-observer variability and the intra-reader variability can vary quite a bit. And we've audited that and looked at this, but I'm going to take a look at some of the things coming down the line which use digitized slides and artificial intelligence programs which can look at things in a much more detailed way than the ordinary pathologist. Which is not to denigrate the pathologists. They're very smart people, but they simply, the human eye cannot discriminate from an AI, an ordinary tissue from AI. And this is a paper from North America, which uses an AI-based program called Arterra. And Arterra looks at a digitized image, and it then interprets that in relation to outcome. And some very distinguished names in the field here from North America, which is Dan Spratt and Osama Mohammed, Howard Sandler, and so on. These are people in charge of big departments in the US. And if you look at the table here, what they've done is taken all of the trials, RTOG 048, the RTOG 9413. These are all largely radiotherapy trials looking at the biopsies. And in grey is the outcome predicted by the pathologist. and in blue is the outcome predicted by AI, with actual follow-up of these patients. So the AI is clearly better than the ordinary pathologist. When we looked at this in the STAMPEDE trial, which many of you will be familiar, we have a translational research program where all of the tissue from multiple arms of the trial are processed in UCL and cross-correlated with clinical outcome, cross-correlated with imaging, and so on. This is a national process where we triangulate all of this data. And this we published in The Lancet. Charles Parker is a research fellow pathologist. He's now moved up the scale a bit. And you can see from the consort diagram here, M0, M1, and you can see the kind of numbers that we're looking at for the analysis altogether. And when we focused on the outcome from the M0 patients, this was whether asking the question, what's the outcome overall? Are they all the same? And what effect does treatment have? And what we can see when we look at the various parameters of outcome in these M0 patients is that the AI actually predicts a group of patients who are much worse. And when we've looked at this in relation to the abiraterone trial, this paper is just out actually in Annals of Oncology about 2 months ago, and it's the same team. And again, you can look to see from this group of patients, these are all the abiraterone patients, looking at M0's overall survival, prostate cancer specific mortality, and so on, that when we plot that in this way, using the same Artera-based technique, so this is digitized slides put through an AI program and cross-correlated with clinical outcome from this study, then we can see again that we identify an MMAI standard high risk, a group of very high risk patients, and when we're looking at metastasis-free survival here, which is a direct correlate of overall survival, we can see that we can identify just by digitizing the slide, putting it through an AI program, who's going to do worse. And this group of patients may well benefit from treatment intensification. Of course, there are many initiatives going on, and Gleason grading, which is very old, is being supplanted by AI, but AI is not the only way of looking at a piece of tissue. This is assessment of biopsy tissue using tumor spectroscopy. And what we know is that tissues emit certain types of waves, infrared, UV, and so on. And the visible light spectrum is really quite narrow. And over a period of probably 15, 17 years, we've developed this methodology with the Manchester University Department of Analytical Chemistry, who are world leading in spectroscopy, and looked at how we can get specific characteristics with deep learning to see how accurate this is in predicting outcomes. So we take a little specimen here, and then we put it, the reader, which costs somewhere in the region of $250,000, and is not available for prime time, but it may well be. We can then look at the characteristics of the spectrum. Rather than just looking at the epithelium, which is what the pathologist is looking at, we look at a variety of others, stroma, blood vessels, etc., and we look at the spectral peaks to see where the cross-correlation is with long-term outcome. And we can then put that through machine learning programs. So what we have here is a tissue microarray, for those of you who have not seen one. Each specimen of tissue represents a sample from a patient, which is associated with clinical outcome, which has all been mapped by our team. And we can then cross-correlate that with the clinical features which we look at: age, PSA, Gleason, bone metastases, and so on. And we can interrogate this very quickly. So the machine, we put it into the machine. It used to take about a week to interrogate one of these. It now takes about half a day. And with augmented computing power and so on, that will get quicker and quicker. And what we found in non-metastatic prostate cancer here, which is what we're talking about now, is that using a completely different methodology, which is not based on anything standard in pathology, actually predicts the outcome in patients in the longer term. And that might help us or give us clues as to what treatments are available, what treatments work, and whether we can improve outcome by reducing types of treatment that isn't going to work and setting up treatments that will. So let me come to this. And in the spectrum, as everybody knows who's in clinical medicine, that the world moves on. And when we were publishing a lot of work on all the trials, we and others in Europe and the US, we were using CT and bone scan. And of course, PSMA has arrived. We knew about PSMA about 25 years ago. We were looking at it in the lab. But it's been now driven hard. And it has a profound impact on what we do. And I'll explain some of that. So it has an impact on the trial populations and logistics, because all of our data that we're working on comes from standard imaging. The sensitivity is higher in some circumstances. It can lead to earlier switch of therapies and a variety of other things, and I'll show you examples of that. Now, this is a classic example of what's known as Buxton's law. Now, Buxton was he was an academic working in Bristol, and he formulated Buxton's law. He was a professor of medical technology, and what he stated is this, that Buxton's law, it's always too early for rigorous evaluation until, unfortunately, it's suddenly too late. And that's absolutely true. And PSMA is a classic example of Buxton's law, where the clinicians start to use it. It reaches a tipping point where people say, well, okay, let's go with it. And everybody gets going. And the enthusiasts drive it. And some of the naysayers say, well, we haven't really tested this. So what's the implication of that? Well, if we take de novo prostate cancer therapy, and we use the conventional imaging approaches, primary disease, node positive, low volume metastatic, and high volume metastatic. Now, the difference in treating these groups of patients is quite profound. So when we use PSMA scanning, this phenomenon happens, which is you get a classic Will Rogers shift. Everything moves from the left to the right, like this. So we start to pick up in what we think is clinically localized disease, lymph nodes. We start to pick up M1 disease in disease which was previously thought to be N0, possibly M+. And we get a whole lot of patients who get rebracketed as metastatic, and an increase in the number of patients who are bracketed as high volume metastatic. So when you think about that, that means that this patient is now, in some centers, being subjected to lifelong ADT combination therapies, possibly chemotherapy, when actually what we know is that the trials of standard treatment are very effective. And this has been driven by a number of areas now. It's classical Buxton's law. Train has left the station. We can't stop PSMA. It is happening. And this paper was from Michael Hoffman, who's a nuclear medicine physician in Melbourne, published in The Lancet in 2020. And what you can see here in blue is conventional imaging. A number of you will be familiar with this paper. And in red is PSMA PET imaging, looking at specificity and sensitivity. Now, clearly, PSMA is more sensitive at picking up small nodal metastatic disease largely. But the specificity isn't that much different. Now, in this study, 14% of the patients had their treatment changed. They were being lined up for radical prostatectomy. It looked like this, so they had a completely different treatment. There was no evidence at all that this shift in clinical practice would have made a difference. There still isn't any evidence about this. Now, where are we a few years on? So this is an illustration of what happens. This is a paper which came out last year on stage migration, and this is from the Belgian team, a very good team in looking at, a radiotherapy team largely, looking at stage migration. And this is what's called the Thunder trial. And these patients were screened for study inclusion, and an analysis was made of conventional imaging versus PSMA-based imaging, looking at Stampede high risk, PSA over 20, Gleason 8, and so on. And this is what happens when you use PSMA scanning. You get a massive stage shift. So any stage migration, you can see that there's a big shift in nodal migration and a big shift in metastatic migration. And as I said just now, that means that patients are being treated, which might have been perfectly well treated with the data from conventional trials where we know it makes a difference. And if you think about it, this is from the Stampede trial. This is Stampede M0, where we randomized patients to receive ADT and abiraterone plus or minus enzalutamide. And when you look at the prostate cancer specific survival, now patients are treated for 2 years here, and you look at the prostate cancer specific survival, this combination roughly halves the prostate cancer death rate. However, using the Thunder trial data, we know that a high proportion of these, probably about 1 in 5, are going to be shifted into the metastatic state. And so they'll have lifelong ADT, plus or minus an ARPI, potentially plus or minus chemotherapy. Now, we've done a number of meta-analyses looking at intensification and de-intensification. So all of these trials we've done with conventional imaging. And the question really is patients with metastatic hormone-sensitive prostate cancer and androgenic pathway inhibitors. And I put this up because this is metastatic, it's not M0, but it is the introduction of abiraterone into this group. And the StopCap team, which is based in London and incorporates all the major trials, and pulls in the individual patient data, analyzes it all. We have an international panel that looks at the outcome, discusses it, and you can see the kind of power that one gets. Just under 8,000 patients between 2011 and 2018. What we can see when we're using ARPI doublets is that everything is to this side of the forest plot. In other words, it works. However, when we start to look at the older patients, these are the 75 plus, in fact, by the time you start adding in things, they're actually disadvantaged by doublet therapy. And there are a variety of things or reasons for that. And I'm going to come back to that in the aspect of some of the translational research we've been doing. So let's get back to high-risk prostate cancer, M0, and ask this question: why not surgery? So in the National Prostate Cancer Audit, we looked at the SEER data, so 109,000, and we looked at the MPCA data, 74,000, and we can get really powerful stuff when we're looking at big numbers like this. And this is CPG1, CPG5, surgery in grey, radiotherapy in black. Now, what's immediately obvious is that in the US here, in high-grade disease, there's a very much higher rate of surgery. And in England, that is about 1 in 5. So the key differences. Now, when we fast frame forward and we just analyze this in the MPCA, that number is going up. And what we know is that at the 5-year time point, at least 2/3 of these patients will need salvage radiotherapy. And the question is, should they have had radiotherapy and ADT in the first place, and possibly with abiraterone, because we know from the Stampede trial, level 1 data, big trial, that you've got a 50% reduction in prostate cancer-specific mortality. Of course, there are unresolved questions. This is a paper which we, again, did through the MPCA. Christian Fankhauser is now a professor in Switzerland, a very bright, hard-working Swiss guy. a real talent. And what we did was look at 102,000 men treated between 2014 and 18, and focusing on those men that we all see from time to time who've got a high-grade tumor and a low PSA. And they do extremely badly. So rather than having a linear correlation with PSA, you've got an inverted tick. And when we look at the outcome from radiotherapy, the risk of death is 5 times higher than the ordinary population. So the question really is, should these patients be treated by radiotherapy at all, and should we be operating on them? And we don't know the answer to that yet until somebody does the trial. And I'm hopeful somebody will. Now, let's come to this, because this is current. And we've been waiting for this for ages. It's long, long overdue. The concept of ADT plus surgery has been around a long time, but surgeons really didn't grasp the nettle and do a proper trial. And we could have done this probably 10 or 15 years ago. And what Proteus showed us, this is the intervention arm, ADT plus apalutamide. So the patients had 6 months prior and 6 months after, and radical prostatectomy. And this is looking at pathological complete response or minimal residual disease. Now, clearly, there's a big difference. But actually, what difference does that make at the end of the day? And the answer is not a huge amount. It's really quite modest, out at 5 years here, with really quite reasonable numbers. So for me, what this study showed was that we need to stratify these patients somehow and work out who are the ones who are the bad actors and who are the ones we can just treat in a conventional way without subjecting them to hormone therapy. Now, there is a signal. It's very clear, pathological complete response, and the secondary endpoints are all positive, but not dramatically so. So it's been a little disappointing, and we've got to plan the next phase of trials, because what we can also see is that when we look at the complication rates for these men who would otherwise have no treatment, they just be followed, is that fatigue, rash, and all of the other symptoms associated with androgen deprivation are going to be foisted on a group of patients with actually relatively little benefit. So, how do we substratify to try to make life much more precise for the patients? Now, this is, I just put this up as an illustration of the Stampede Translational Program. And this is from one of our research fellows working at UCL. This is Emily Grist. She's now a consultant medical oncologist at UCL as of this year. And this has looked at copy number alterations, in other words, how disrupted the genome is. And you can see from the map where the tissues have come from. So it's not focused on London. It's all the Stampede centers, or most of them. And you can see here M0, N0, M0, N plus, M1 low, according to charter criteria, and M1 high. And each one of these box and whisker plots illustrates just how disrupted the genome is in these situations. So what we can see from this is that very clearly M0, N0 prostate cancer is a different entity to M0, N1. And when we consider M0, N1, it's pretty much the same as M1 low. And so the question rises, could we use this kind of methodology? And there are others, and the AI program is one, where we might say, okay, well, if we do a radical prostatectomy on this individual, he's likely to do pretty well. Whereas if we do a radical prostatectomy on this individual, he's probably got the same outcome as an M1 low patient. We're working on this at the minute, addressing this question, the biological subgroups of aggressive disease with established efficacy in late disease. Now, many of you will be familiar with the PARP inhibitor trials that have come through, all in late-stage disease, and just more recently, 2 trials in hormone-sensitive disease, but none in clinically M0 disease. And this is a trial which has been put together by the Stampede team, but actually driven predominantly by Ashwin Sachdeva, who works with me as the academic clinical lecturer in Manchester. A tremendously talented and hardworking guy. So this has been funded by AstraZeneca as an investigator-led phase 2 study, looking at BRCA alterations and targetable with PARP inhibitors, a randomized half and half. Now, you might think, so what? That's not a big trial. Actually, we will have to screen about 2,000 patients to get the 200 or 180 that we will need. And then we will randomize them one half to receive saruparib, which is the new PARP inhibitor from AstraZeneca, and the others will receive standard of care, which is observation. And we'll treat them for a year. And if that works, then we'll roll that out in a bigger phase 3 trial. So we have about 8.5 million funding from that bit, and then that leaves us with a whole load of patients that have got their disease characterized genomically, and we can then fit them into a stratified treatment trial of observation, post-radical prostatectomy, versus intervention. And this is important because when you think about that slide which I showed you of Christian Fankhauser's work, published in European Journal of Cancer, there are some patients who don't respond androgenically. And we all know that we get patients who just plow straight through the ADT, whether it's alone or in combination. And this seminal paper looked at the disruptions in cellular pathways in prostate cancer. And there are two areas I'm going to focus on. That's the PI3 kinase pathway, known as the PTEN pathway, which is a non-androgenic pathway, and DNA repair, which is where Stampede 3 is coming in. Now, this is a complicated slide. We published this in British Journal of Cancer in, I think it was 2022, 23. And what we had done was we had used multiplex fluorescent imaging. Each one of those is a prostate cancer core from our TMA. And we had followed these patients. We collected them all between 1993, 94, and about 2011. We had extended follow-up, 20 years in many of the cases. And the basis for that, when we were discussing how we measured the end point, was you can't argue with prostate cancer death. If the patient's died from prostate cancer, that's a defined endpoint. And we looked at the various markers. Now, these are years, and you can see that there are certain markers which are associated with migratory behavior. In other words, the cells start to show signs that they're metastasizing. And when you then measure this in a micrometer way, you can focus in on the very edge of the prostate and measure P10, FRNA2, which is something which causes cells to migrate, phosphorylated FRNA2, and this one, which is a marker of what's called EMT, epithelial to mesenchymal transition. And what we can see is that if you have a combination of P10 loss and phosphorylated FRNA2 loss, you're down here. So just treating those with ADT in the longer term is probably not going to be a brilliant idea. So should they be treated with P10 inhibitors, or is there another reason why they're doing badly? So there are some sophisticated trials which are being done at the moment. This is what's called EVO-PAR, which is the radiotherapy equivalent of Ashwin Sachdeva's trial. This randomizes high-risk patients to saruparib and placebo, and saruparib and abiraterone versus abiraterone. So a complex trial, high-risk prostate cancer patients who are HRR, homologous recombinant repair mutated. This is recruiting. It'll be a little while before it reports. And this is its sister trial, which we hope to get started probably in the first quarter, possibly the second quarter of 2027. This is Stampede 3, which is a purely surgical trial. The first one we've ever done in Stampede. And the basis for that is really what I've been talking about, which is that there's a group of patients who are high risk, and we know they fail, and we know that they go on to develop metastatic disease. So the failure rate in this group, biochemical failure rate, is probably about 50% at 5 years, and the death rate is about 1 in 10, possibly 1 in 20. But if you follow them longer than 5 years, well, these are the ones that are going to go on and get metastases. So we will treat these patients with radical prostatectomy and divide them into a group that are observed and a group that are characterized and treated. So let me just show you how we're going to do this. So when we've got a prostatectomy, and we've got multiple centres across the UK who've agreed to join this study, we then take the tissue blocks, put them through the central Stampede machinery for processing samples, and we work out who's got an HRR mutation, and particularly who's got a BRCA2 mutation, and we randomise them to standard of care and saruparib. But, and we will do a variety of other things, looking at genetic profiling, nanoprobe technologies, Veracyte, and Artera. Artera is the AI-based program on straightforward pathology. And it will be fed into this kind of trial schema, which is mismatch repair deficient, prognostic biomarkers, so immunotherapy, docetaxel. We know that P10 is much more responsive to docetaxel, and darolutamide, and we can embed those future trials within Stampede 3. But at the same time, we will engage with our translational trials team or translational molecular biology teams, and this will be internationally based. We've got a whole team at Manchester, a whole team at UCL, Australia, and the US, to look at the sophisticated elements of why some of these tumours are so aggressive, and can we target them effectively? In other words, can we understand the biology a bit better? So that's coming along. So I'm not going to talk too much about this because there's an awful lot of stuff which is mentioned at the meetings. Suffice to say, one of the bigger expanding areas which urologists need to get involved with, and in the UK they're stepping back for all the wrong reasons, and it's been taken over by medical oncology. And it shouldn't be, because urologists actually are very closely involved. And just to illustrate how we can use basic imaging to change world practice, I put this up. Now, Adnan is from this part of the world, and he's very bright. He worked in New York, and then he came across to us as a PhD to do molecular biology. That's what he wanted to do. And we set him to work doing various things, and he's now running clinical trials, I think, in Australia. But he and Alex Hoyle, who's a consultant with me at Salford, we put them into the analysis of metastatic burden. And we worked this out, really, with a paper we published in 2013, which is that the critical number of bone metastases on a bone scan was about 5. And there was a real dichotomy at that point. So we applied this to the Stampede trial, and what we found was that low-volume metastases benefited from radiotherapy, and high-volume metastases did not, which tells a lot about the biology of the cancer. In other words, the primary is driving the disease up to a certain point, and then it takes off. And so that was defined as a full predictive marker. It's still the only predictive marker we've got in this setting. And it was done by pulling in the scans. We have about 11,000 scans on the servers in Manchester now, analysing them and cross-correlating that with the data from Stampede and from national data sets, which we now are able to access. And the other thing which we can do in a much more sophisticated way, but it's actually becoming mainstream now. This paper was in Cell in 2025, and has been practiced, or should I say, it's changed the way people think about how these cancers are addressed. So the tissue comes in, the transcriptome is analysed, it's linked up to outcomes, and we can see what the RNA status is. And what we've been able to show with this, and it's Emily who did all the work with us supervising, what we've been able to show is that we can identify patients who will respond to docetaxel based on their P10 status. And when we look at the gene profiles for these, and don't try to read this too much because it's just too complicated for me to go through in such a short space of time. But the non-metastatic and metastatic are here, and we've got Decipher high, Decipher low, and what we can show by the analysis, this detailed analysis and molecular profiling, is that low volume metastatic disease behaves quite differently to high volume metastatic disease. And we're currently looking at the cytokine profiles and other biochemical markers. And this is published in Cell. And just to illustrate the point without laboring it too much, this is the P10 deleted treated conventionally. And what you can see is that they are a really bad group of patients. They're the ones actually that don't respond very well to ADT. So for the last few slides, I'm just going to go through the real world, because what we're doing to patients is intensifying treatment, and that has an effect on our patients. So we've been looking at non-cancer mortality. In other words, if we're looking at the results of a trial, everybody focuses on the cancer-specific mortality, the metastasis-free survival, and nobody looks at the non-cancer mortality. Now, for those older members in the audience, you will remember the 1976 BIOS study of estrogens, where estrogens were used universally from 1941-42 until it was proved that the estrogens were killing off the patients more quickly than the cancer. So that was stopped. We've actually reversed that a little bit. But so Omar Al-Taji, absolutely outstanding research fellow, we've looked at the cumulative incidence of non-cancer mortality in patients having ADT, ADT docetaxel, and abiraterone. And because we've got access now to public health records, we can see what patients have died from. So if they died from prostate cancer, we can censor that. If they died from something else, we can censor that. Heart attack, stroke, whatever it is. And we get that out to 8 years. And what we can see is the cumulative incidence of non-cancer mortality gets higher and higher for certain patients. And when we factor those for certain types of treatment, ADT docetaxel, ADT abiraterone, we can see what we've just shown with the meta-analysis, that abiraterone actually has a cost in the older patient. And this, just to show the slide again, is what the cost is, which is the over 75s don't do that well. You're actually making them die sooner because they die from non-cancer mortality, metabolic problems, heart, stroke, major adverse cardiac events. So just to bring this down to earth, rather than sophisticated molecular biology, everybody does a routine scan in our patients, and by and large, we ignore most of the information that is contained within it. And what we have been doing is interrogating these scans using sophisticated programs which will measure things like visceral to subcutaneous fat, volumetric liver density, aortic calcification, and so on, in a very large number of patients. Now, this is a huge amount of work for Omar and the team, and you can see the scale of this when you look at the linked data cohort. So pulling in scans from all over the British Isles is taken us probably about 12 years to achieve. But then it's very powerful. We have about 6,000 patients, 2,300 M0, 3,900 M1s, and we can analyze by looking at the scan. So we take a cross-sectional image of the CT at L3, and we do a measurement of aortic calcification. And the results are fascinating. So this is what happens when you do that. So here we've got clusters of patients. We've got a cluster that is cardiovascular, measured by aortic calcification. We've got a cluster who've got metabolic problems, they're big, heavy, diabetic, and all that. And then we've got a fit group of patients. And when we put all these factors through, liver density, spleen volume, bone mineral density, and so on, we can see these patients categorized into certain areas. So patients who've got a cardiovascular risk profile do very badly with certain treatments. Patients who've got a metabolic profile do very badly. And no matter what age the patient, if they're fit, they do very well with everything. And all of this is available, or will be available, just as an online app. You put the scan up, put the program in, it takes about 5 minutes to run, and it will spit out what the risk profile is in a much more sophisticated way than we would ever have done by just looking at the patient thinking, well, you don't look very fit to me. This will definitively measure it. And that's important because what we can see here is the influence of age on treatment. Again, this is national audit data, and I put it up to illustrate the watershed for treatment. This is all the patients in England, percentage of men with high-risk locally advanced cancer undergoing radical treatment. And you can see they start to tail off, 75. Now, for those 75-year-olds who are pretty fit, and you were to say to them, well, you know, we're not going to operate on you, mate, or we're not going to treat you with radiotherapy, they get a bit upset about that. But we have to be realistic that everybody dies of something. And if we're going to treat patients in this area here, and this is the data on SACT treatment, doublet therapy, we've got to be able to weed out those patients who are fit enough to have aggressive treatment because they've got a long life expectancy, and those who are multiply comorbid, who really their life expectancy is quite short. So, the landscape of precision medicine, it's the history of the world in a short space of time. I can't cover it all, but I hope it's given you a flavour of just what's happening. Thank you.
Thank you, Professor. Questions from the audience? Any questions?
Thank you for the wonderful talk, Professor. So I've got a couple of questions. So we're all in the PSMA era now. Are we any close to finding out what exactly is an oligometastatic disease in the PSMA PET?
Well, it's a very good question. The answer, in a word, is no. Its definition varies according to which part of the world you're in and according to which part of the country you're in. When we were setting this up and planning the Stampede oligometastatic, we could see from Adnan Ali and Alex Hall's work that the threshold was 4 bone metastases. And we were working with a philosophy that we wanted to augment that, so go beyond what we knew was going to work. And we set the figure at 5 for conventional imaging. And we still have that, but we are allowing PSMA in. Now, if somebody who's got conventional scan negativity and their PSMA is positive, well, I'm hopeful that we will ultimately start to unpick some of this. But Buxton's law is prevailing, I'm afraid. And what we know, we've known for quite a long time. So if you think about the detailed lymph node dissections that were done by the European teams, 1,000 patients, Gleason 8, PSA 20, the metastatic, micrometastatic positivity was in the region of 80-90%. So PSMA is not telling us anything, but the clinical community is not listening to any of that. They've forgotten it, and they're moving forward. And I think that's a problem. But I think the only thing we can do is attack it with data, and ultimately look at the natural history, which is going to take a little time because these cases are, the natural history is quite long for M0 prostate cancer.
Okay. So I get the distinct feeling that you're not a big fan of PSMA, but is the Will Rogers not a good thing for the patient to be better substratified?
Well, if I can answer that perhaps in 2 ways. I think PSMA is a good thing when it's used properly. We use it when patients have had a radical prostatectomy and the PSA is starting to rise, and we're considering whether to irradiate the prostate bed plus or minus the lymph nodes. And then it's very valuable because if the scan is negative, we irradiate the prostate bed. We've got good evidence to do that. However, if we see lymph node positivity elsewhere, well, and nothing in the prostate bed, well, the patient's just going to get the toxicity without the benefit. So we do use it for that. What we've resisted is using PSMA for staging, because our view is that you can do a PSMA, but what we know is that you've got a very good outcome. Let's say you present with M0 prostate cancer by conventional imaging, and then somebody goes off and gets a PSMA done, and somebody says, well, look, he's got a lymph node in the iliac region. You can say, well, actually, what we know from Stampede M0 is that this individual is going to do extremely well with systemic treatment. So the natural history studies have not been done, and we have, as clinicians, to deal with that. It's not always easy to explain that to a patient, unfortunately.
So the next one is regarding Proteus. You were suggesting that a patient who may not need ADT and RP is going to be subjected to one without proper evidence. But you look at the other side of the coin, this is a high-risk patient. He's going to get 3 years or 2 years of ADT. Is 1 year of ADT and RP not better than 2 years of ADT alone, or 3 years of ADT with radiation?
Well, one has to look at the patient benefit at the end of the day and the number needed to treat to get benefit at the 10 or 15-year time point. So when we were looking at using docetaxel, for example, in high-risk M0, the JETUG 12 study from France, they followed patients for 12 years before they could see a marginal difference in the outcome. And in Stampede, we did the same. We followed them for 8.5 years, and it still hadn't reached significance. So giving those patients docetaxel is absolutely no good at all. And I think that is something which we need to bear in mind. Now, I think as an interrogation of pathophysiology, Proteus, which is a very well-done study with some very talented people, has told us a lot. But it hasn't actually answered the question, should we be treating these patients? Because the natural history is not there with that extended period, which we need for an answer.
Right. So I won't hog you all. So the Australians have moved again, to going to do radical prostatectomy without biopsies. I just saw a paper in the Society of Robotic Surgery meeting where they've done 100 radical prostatectomies with just the MRI and PSMA PET, and it's been 100% positive. What are your thoughts on getting to do a robotic prostatectomy without biopsies? For instance, we do it for kidney cancer all the time. Is that such a bad thing to do it for the prostate?
I think it's absolutely crazy. Yeah, I think it's poor medicine. Because we know that if we've got somebody, let's say he's 72, 73, and he's got a significant lesion in one side of the prostate, is that Gleason 3+4? Or is it Gleason 3+3? And we see this all the time. So if you go back to the paper which was written by Nick George, who was my mentor, in 1988 in The Lancet, he had 170 patients who were treated with TUR alone. These were T3 patients, and a high proportion of those had intermediate or low-risk disease. And it may surprise you to know that over an extended period, there was one prostate cancer death in the whole 170. And that's really what Protect is telling us. That's what Sammy Franks told us in 1954. So why don't we learn that history lesson? Nobody's heard of Sammy Franks, but it's all written there.
Okay, last question from me. Do you have a personal preference with Decipher or Artera or Oncotype DX?
Well, they work differently. That's the problem. So I'm hopeful. I mean, the beauty of doing a radical prostatectomy in high-risk cases is you've got all the tissue, and you can map out the different methodologies. And one of them is going to be better than another at some point. And it's a little bit like, which VHS recorder do you actually have? And Betamax versus VHS, and VHS ultimately won. So we will go with one at some point, but it needs testing on large-scale data sets, and they need to be validated. And it's important to bear in mind that here we are in India. There are no Caucasians in the room, as far as I can see, but we haven't got many Caucasians in our tissue bank for patients undergoing treatment. So we need to recapitulate this and see really what the ethnic differences are. The Japanese are obviously very different. They respond very well to ADT.
Thank you.
Any other question? Yeah, Manas.
Good evening, sir. I'm Dr. Manas from Curie Hospital. So, we spoke about the non-cancer mortality in ADT when we start ADT or ARPI, and you gave us a picture of what can be the ratio of non-cancer mortality. How do you evaluate, or how do you choose your patient? Do you not start? Suppose the patient is having arterial disease, but is a candidate and will benefit from an ADT. Is there a specific way in which you differentiate which patient will you start an ADT only or an ADT plus ARPI? Will you restrict yourself from starting ARPI in a patient with a metastatic, maybe a oligometastatic disease?
I think you have to keep on thinking. This is why surgeons should be good physicians. Because when you get a patient who comes in and you can see that his memory's not that good, you can see that he struggles to get on the couch, you look at the list of medications he's on, and then you ask yourself, how long is that man going to live? And we know that in my area, a fit 75-year-old has a 10, 15-year life expectancy. But in some parts around the hospital I work, a 65-year-old who's multiply comorbid is unlikely to get beyond 70, 71. So you have to tailor that with the life expectancy on the one hand. The second thing is that ADT is a toxic treatment. You have to remember that starting ADT, particularly in somebody with a serious cardiac comorbidity, can give them a heart attack or stroke within the first 6 months. And that's very clear. When you also think about other aspects of ADT, bone volume, for example, which I did my thesis on bone volume, and you get an acute drop in the bone volume in the first 6 months, and it doesn't recover. Sexual function in the 75-year-old, I mean, mostly it's gone as soon as you start ADT. So all of these factors you have to play in. So you get a 74-year-old, 75-year-old, 78-year-old fell runner, well, who runs over the hills, yeah, he's going to be fine, isn't he? Whereas somebody who comes in with a walking stick and clearly has other comorbidity, overweight, diabetic, bit of angina, be careful before you start the ADT because the natural history is maybe quite long.
Yeah. So as you said, fit 75 with being a candidate for ADT or ARPI, will you be, and you are the first one in the clinic who diagnosed it, okay, he's having a cardiovascular or an aortic disease, who should be eligible for starting a blood thinner or some other medication per se. Would you be starting it along with ADT, or will you, how will you assess?
Well, currently...
Or do you routinely start?
Well, anybody that's done vascular surgery knows what the vascular tree looks like. And you can see, somebody who's an arteriopath from the end of the MDT room. And so I would be a bit circumspect about it. But generally speaking, you have to take a history. You have to examine the patient. And so many surgeons, junior surgeons coming through, don't examine the patient. I often have to send them back in and say, well, what's his blood pressure? Oh, I didn't measure that. What's his heart rate? Have you noticed he's in AF? Have you noticed the cannon waves in his neck because he's got mitral regurgitation? All of those things. So you have to keep on thinking and then make a decision in discussion with the patient. Because the other thing, which is we've not really spoken about, is the brain fog that goes with some of these treatments. The intellectual drop-off, which clearly occurs.
Hi, with regards to initial talk, basically you just spoke about the AI-driven digital pathology. Yeah, basically, are you doing it? Are you asking the pathologists do it with regards to digital pathology? And then, because will they be offended if you tell them that, because inter-observer variations, are you going to do that, or are you going to allow the pathologist to do it?
You don't want to upset your pathologist. That's a very bad thing to do. Yeah. We work very closely with pathologists. And not across the whole of the city, where we keep an eye on certain pathologists and just how good we think they are. But we have research pathologists who are integrally involved in this program. So Professor Jan Burney in Barts is the lead pathologist for this. Pedro Oliveira, who's a research pathologist at the Christie. So it's horses for courses, really. But we like to keep the team in. So we've got subspecialty radiologists, subspecialty pathologists, and so on. Collaboration is very helpful.
follow-up question. I was talking. The first second slide, I noticed the Gleason score, Gleason GG2 and GG3, and then there was a missing data of about 19%. I'm very surprised that in UK we are having missing data about Gleason score, which is usually not the case. Why was that?
Well,
Or what am I missing here?
I think some of the hospitals are just overwhelmed. We accept that we're missing data, and we can impute certain things. In other words, if a patient goes on to chemotherapy, for example, then we can impute that they've probably got metastatic disease. So we narrow down the numbers. But the way we try to get around it really is to, because the numbers are so large, so it's almost like a Bayesian approach rather than a null hypothesis approach, because if you've got 250,000 cases, well, the error is and it's the same with every public data set. So the SEER data set, there's lots of missing data in it. Yeah. And so what we've endeavored to do, and you saw some of this yesterday, Raghu, is to match the trial data sets with the hospital episode statistics from real world. And that gives us a good indication of just how accurate a trial is in relation to the kind of patients that we all have coming to our clinics.
The other question I wanted to ask is, there was a lot of discussion about P10. Do you use a IHC or a genomic marker or NGS or something to do the P10 deficiency?
So the CAPI-281 trial used IHC, and AstraZeneca are very keen to continue with IHC. The Emily Grist data, which I showed you, used transcriptomic data, in other words, RNA. And so there are subtle differences in how the tissue types respond to docetaxel. So about half of the tissue types on transcriptomic analysis will respond very well, and the other half won't. But what the CAPI-281 study showed, and this is published, is that if you had more than 95% of the tissue in the prostate biopsy, which is P10 deleted, you got a very much better outcome. And that's driven the registration through the FDA.
Because we were trying to get the IHC marker for P10, and we went through quite a few companies, and it was not sort of doing well. So I wanted to privately take the company which is doing it. There is a lot of discussion amongst the medical oncologists, and we are also looking into it. Especially India has no dearth of high-risk metastatic prostate cancers. Is the advanced prostate cancer the consort, that is P10 deficient, P53, and RB1? Is that something you use as well, or is it only in the medical oncology myths?
Well, it's a research tool. So we sit in the same room. So every Thursday afternoon, we'll discuss 40 plus new prostate cancer cases. And in that room, there will be 3 surgeons, there will be 2 medical oncologists, well, clinical oncologists, research pathologists, and so on. And at the moment, we're constrained by funding. So from the clinical point of view, if patients have got certain characteristics, for example, a 55-year-old presenting with high volume metastatic disease, we can genotype those, and that they get germline and they get tissue. Because we've got such a big research practice, we can genotype the tissue looking for somatic variations. But we don't, it's not universal yet, it's not mainline.
It's not universal.
Yeah, it has to come, I think, but not yet.
Thank you. Thank you so much. I mean, I can keep asking more questions, but others will get angry. So I'll stop there for the timing. I'm going to give you some voice rest for a few minutes. And you want to continue more, or?
No, I think there are 2 other talks, aren't there?
Yeah, we'll ask Anant and
somebody else needs a chance, I think. I'll finish up with something a little bit lighter later on.
And thank you so much for being there. And this occasion, I'm going to invite Professor Sivaraman to come and honor our MUS President, Chengalvarayan. Please come, sir. Professor Sivaraman. Okay. Yeah. And thank you so much, sir. Can I request Professor Jayaraman to honor Griffin, please? As always, the formality is I'm going to invite all the dignitaries to come along and light the Kuttu Vilakku. Can we arrange that? Yeah. அங்கே இருக்கட்டும் அங்கே இன்னும் இன்ஃபேக்ட் கொஞ்சம் தள்ளி போனால் இட் வில் பி ஈஸி ஃபார் பீப்புள் டு கொஞ்சம் தள்ளி கொஞ்சம் ஒரு ஸ்டெப் தள்ளி அப்படியா சரி எம்ஜிஆர் சார் ப்ளீஸ் ஜெய் கணேஷ் சார் எங்கே டிஜி சார் போயிட்டாரா பிரகாஷ் சார் ப்ளீஸ் மணி சார் ரஃபீக் சார் ப்ளீஸ் கம் பிபிஎஸ் சார் சார் வாங்க சார் ப்ளீஸ் Professor Clark, please come along. This is a tradition of our country, so please. Yeah, please, anywhere. Anywhere in between. Madhav? Professor Karnamurthy, Vanga. Sendil sir. TG sir. Please. Photo. Adhikaga Vanga, please. Muruganandam. Sri. Vada. Jay வந்திருக்கான். Hey Jay.
I started earlier. I'll first set.
சரி இல்லை இது ஜஸ்ட் ஒரு பிபிடி ஸ்லைட் தான். Thank you. And after that very short break, it's absolute pleasure to introduce my good friend Anand. Known each other for almost 15 years now. Amazing robotic surgeon. I've seen him operating so many times. A very good academician, very strict clinician, and now director of Curie Hospital. He does some amazing work, and it's a pleasure and honor to have him here. Thanks, Anand. It's your stage. There's a lot of accolades for Anand, which I don't need to tell. Everybody knows about it. So it's a pleasure, Anand, to have you here. You have the attachment? You have it.
திரும்பி எடுக்கணும்னு நினைக்கிறேன். Good evening. First and foremost, I must thank Professor Raghavan for inviting me to give this talk. And it's an absolute honor and a pleasure to see Professor Noel Clark talk. He's always been one of my heroes. So thank you, Professor, for coming down to Chennai. And when Dr. Raghavan asked me to talk about in today's event, he suggested that it should be something that's useful to the postgraduates. So it's going to be more of a talk that traces where we are and why we are at this point in time with regards to ADT. So you know, whenever you talk to a radiation oncologist, and when we have debates saying that what is better, surgery or radiation, is really not a fair comparison, because you're comparing radical prostatectomy with radiation with 3 years of hormones, right? So it's never radiation without hormones in a high-risk setting. So that's the dichotomy that we have here, and that's what I'm trying to explore out here today. So I'm going to look at about 6 points here about in what were we doing in 1941 to 97, 97 to 2009, and again, where was urology during that period, and then the missing data, and why is the reason for this evidence gap that we have, and what are the questions that we can go ahead with. So 1941, this is where everything started. That's Charles B. Huggins, along with Clarence V. Hodges. They were responsible for finding out that ADT, the prostate cancer, is androgen dependent, and androgen deprivation becomes the first systemic therapy for the disease. So 1966, Huggins was awarded the Nobel Prize for this. And in the 1960s, you had the VACUG trials, which is Veterans Administrative Cooperative Urological Research Group, the US-based group that confirmed ADT's palliative benefit, but not cure. So they tried various approaches to ADT. Of course, orchidectomy was one. Then those days, diethylstilbestrol was given. But they gave 5 milligrams, 1 milligram. What they found was 5 milligrams was a bit too much, resulted in a lot of cardiovascular complications. Why? Because of the first pass metabolism. So you take diethylstilbestrol, it goes to the liver. Not only does it reduce the anticoagulants, it increases the procoagulants. So that's the reason why a lot of these patients had cardiovascular morbidity and mortality. Now, is there a way to avoid that? Can we avoid the first pass metabolism? And I think we have Professor Clark here, who was responsible for the patch trials and the Stampede data that looked at estrogen patches. So currently we know that 1 milligram diethylstilbestrol doesn't have that much comorbidity. But then again, one step further is estrogen patches also doesn't have that level of comorbidity when you compare it with LHRH agonists. They've not been compared with antagonists, but with agonists. So UK is a leader in applying patches, estrogen patches, to treat metastatic hormone-sensitive prostate cancer. Currently, we don't have those patches in India, but soon to be available. So 1941 to 2026, 8 decades. First, you have Huggins and Hodges. Then 1987, you had the RTOG 8731. I will talk about it, where they found that ADT and RT beats RT alone. The neoadjuvant ADT plus RP trials, radical prostatectomy, there's mostly a lot of American trials that didn't show any benefit. And then we had the RTOG 9202 in 2003 to 09 that showed that long-term ADT is better than short-term ADT. The only positive surgery trial, that is the missing data, that came out in 1999 to 2018. And I'll talk about it as well. And currently where we are with Proteus. Now, Professor Clark already alluded to this. No complete randomized trial has ever tested years of adjuvant ADT after radical prostatectomy against prostatectomy alone. So there is an evidence gap here. Even now it's existing. So this is the first step that I'd like to take you through, important for the postgraduates. EORTC, that's European Oncology Research and Treatment Cohort. Now the trial that started the RT plus ADT standard, this was the New England Journal of Medicine 1997 BOLA trial. So 3 years of adjuvant ADT plus radiation significantly improved 5-year overall survival versus RT alone. Right? That's the first step that we need to know. 79 versus 62% in phase 3 randomized control trial. T1, T2 poorly differentiated, T3, T4, N0, N0 and M0 patients, mostly bulky disease. All of these patients had not only pelvic radiation, that is to the nodes and to the prostate bed, but a prostate bed boost of around 20 gray, which is 70 gray total. So definite evidence that ADT plus RT helps than RT alone. Next one is confirmation with ADT for life. So this is RTOG Radiation Therapy Oncology Group. Now the name has changed to NRG now. So that's 8531, which means it started in 1985 and the 31st trial in 1985. And androgen suppression adjuvant to definite radiotherapy in prostate carcinoma. So indefinite ADT significantly improved 10-year overall survival, disease-specific survival, metastasis-free survival with RT, with deferred ADT. So for instance, these patients would be given, poor risk patients, would be given ADT for life versus when they progressed. What they found was giving them initially definitely made a difference. 49% versus 39%. And all of these studies showed an overall survival difference. That's not something that we see very commonly in the newer trials that are running at the moment. And primarily because you need to wait a long time to get this data, overall survival data. We're using surrogates at the moment, but I think that's the way forward. So next one is RTOG 9204. Is short-term ADT better than long-term ADT? Again, 4 months is not enough. That's what they found. So 28 months of ADT significantly improved 10-year disease-specific survival and distant metastasis versus 4 months. The first randomized control trial proved that duration itself matters. So that's something important as well, 89 to 84%. So then again, the question arose, can we just get away with 6 months? Why not, should we give 3 years? This is again the same BOLA team that did this study. and they wanted, it was a non-inferiority trial, and at that time this was rejected. 6 months ADT was not enough. 3 years of ADT significantly lowered 5-year overall and prostate cancer mortality versus 6 months. So this is primarily radiation oncology driven trials, also industry sponsored. By 2009, radiation therapy had a complete evidence ladder. So that is, initial Bola trial 1997 gave this answer that ADT clearly benefits along with radiation. Then short versus long-term ADT, that again was answered, you need long-term ADT. Short-term ADT was not enough in the high-risk setting. And the result became a standard of care. All radiation in the high-risk setting had at least 2 to 3 years of ADT. And nobody's ever questioned this until now. So all of the comparative trials between surgery and radiation were looking at this dichotomy. Primary treatment plus ADT versus primary treatment surgery alone. And this was the trouble, right? What were the surgeons doing all this while? Did they not have the idea to give ADT to their patients? They did, but not in the right way. So this is Dr. Soloway. I just met him last week in Miami. He's one of the chief surgeons was one of the chief surgeons at Miami. Still sharp and bright. So they looked at neoadjuvant androgen ablation before radical prostatectomy in CT2B NX M0 patients. And what they found was no difference in 5-year biochemical recurrence-free survival, despite a significant drop in positive margins. So pathologically, they were affecting the tumor, but they were not touching what the ADT could do to distance spread. I personally think it's because of very short-term ADT that was given as a neoadjuvant setting. Again, clots in Canada, despite a 50% reduction in positive margin, no overall biochemical free survival benefit after 6 years. Again, this is what started this era where they suggested that neoadjuvant hormone treatment did not have a benefit in terms of surgery. So the radiation guys were doing it, but the surgical guys weren't doing that well enough. So all of these trials were negative, consistently negative. More than 20 RCTs, 1992 to 2003, Fair, Soloway, Kloss, Shulman, and a lot of others. Neoadjuvant only, most were short course, 3 months before surgery. And the rationale was shrink the tumor, reduce positive margins, but the endpoint reached was pathology, but not systemic micrometastatic cure. That was the problem, right? But the radiation guys had the forethought to do this, right? What made radiation work with ADT? They continued it for about 3 years. And the rationale was radiosensitization of the tumor if they started along with during the peri-radiation period, and to eradicate micrometastatic disease later. So endpoint reached, overall and disease-specific survival. That's the key here. Overall survival is the key. No surgical trial had shown that, or did it? So this is the only trial that showed a survival benefit, and this is the messing data, Eastern Cooperative Oncology Group, long-term ADT after RP, and this was only for clinically node-positive, pathologically node-positive disease. They were given long-term ADT, and it did significantly improve overall survival versus deferred treatment in node-positive men after RP. Only positive trial, hazard ratio is 1.84. The next step is SWOG S9921. So in this trial also something what we want has happened. So surgery plus 2 years of ADT, but they were comparing two other entities here. Surgery plus ADT plus mitoxantrone and prednisolone versus surgery plus ADT alone. So this trial had to be stopped halfway through because the mitoxantrone cohort developed a lot of leukemia. And there is no comparative arm without adjuvant ADT, so it cannot tell us whether 2 years of ADT itself is what drove the favorable event-free survival seen in both arms. So again, it's a missed opportunity for us. They should have had an arm that did only that. Right? So two local therapies, two very different evidence bases. So first you had local treatment alone, along with local treatment in ADT. In radiotherapy, it was done. It was positive. but never tested with adjuvant multi-year ADT in surgery. Right? Short versus long duration ADT again was positive in radiation, but no long duration trial ever done in surgery. So long ADT in node positive disease, this was the only thing where we had data, and that was the missing data, and it was positive. Overall survival was positive in surgery as well. So the backbone tested against no ADT control in modern era. This has been assumed since 1991 Bola trial in radiation. Nobody ever questions it. In surgery, it's still not yet happened. Professor Clark alluded to that as well. So we are tailgating into the Proteus era now. And why is that happening? Right? 2017 to 2019, there are a lot of new drugs coming in, ARPIs, RPs we call them, right? Abiraterone, apalutamide, enzalutamide, darolutamide. So you had Latitude, Titan, Arches, and Spartan. Latitude with abiraterone, Titan and Spartan were with apalutamide, Titan with metastatic hormone-sensitive prostate cancer, and Spartan with non-metastatic CRPC, and Arches with apalutamide as well. So all of these trials came into the picture. These agents are far more powerful androgen receptor pathway blockers than in the 1980s, 1990s LHRS agonists and flutamide that we had. And small phase 2 neoadjuvant studies as well, apalutamide monotherapy before RP showed a definite pathological improvement. So this revives the exact hypothesis that we had in the 1990s, the surgical trials rejected, but now we have better tools. PSMA, MRI, genomic classifiers. Can we ask the same question again, and can we get a different answer? And that's what Proteus is, right? So these are some of the studies that came in before Proteus. CalGB looked at chemotherapy. This is all part of treatment intensification in the perioperative period for these are high-risk patients of prostate cancer, right? So Taplin study, dual AR blockade trials, and then finally Proteus as well. So my goal here is to talk about Proteus, and I've given you the historical context as to why Proteus came into vogue, right? So perioperative apalutamide in high-risk localized or locally advanced prostate cancer, 2,000 patients, 1:1 apalutamide versus Proteus, 100 apalutamide versus placebo, 184 sites with 18 countries, and 60.61 months median follow-up. So trial design, 12 cycles, neoadjuvant before, 6 months, and then surgery, and then followed by adjuvant. You would stop the apalutamide 2 weeks prior and 4 weeks later, but you would still continue the LHRH agonists. And dual primary endpoints, pathological complete response or minimal residual disease. And this is a surrogate. We don't have overall survival data, and the metastasis-free survival is what we are using right now. So pathological complete response or minimal residual 9 times higher. But actually, we call it 9 times higher, but it still leaves 90% of the patients still not having pathological complete response. So is that all what it's supposed to be? Right. So then positive surgical margins definitely came down 20 to 42.7%. And it's a reasonably good surrogate. It's not the perfect surrogate. It's a reasonably good surrogate, I would say. And disease stage 53 versus 70%. So MFS events, again, 215 versus 1,057 versus 257 versus in 1,052 patients. But mostly driven by PSMA PET and not conventional imaging. So there's consistent benefit across hierarchy as well. Event-free survival, time to first subsequent therapy, time to metastasis, freedom from disease at 4 years, MFS and PSA-free survival plus testosterone recovery. Only that was a bit different, but otherwise everything else was pointing towards apalutamide. So Professor Clark alluded to this. Definitely more side effects with apalutamide. But I think if we use other class drugs like darolutamide, would we reduce the side effects? Would we carry the same benefits? That remains to be explored. But I think in future, darolutamide might come up in a big way, because I think, at least from what we've seen, is relatively less side effects compared to enzalutamide and apalutamide. So what to weigh before changing practice? The strengths, it's a large, well-powered phase 3 double-blind trial. And perioperative ADT itself is treatment intensification beyond guideline recommended RP. So if at all, it adds to the strength of this trial. So initially when they spoke about BOLA trials, everybody said the lacunae in those trials was they didn't have a ADT alone arm. But here we do have an ADT alone arm. So I think it adds to the strength of the trial. Dual primary endpoints both met statistical significance. Consistent benefit across secondary and exploratory endpoints, and pathological response prospectively correlated with MFS. Again, this leads us to ask the question, if somebody has a pathological complete response at 6 months, should we even continue the RP and ADT for the next 6 months? Again, remains to be seen, but as per trial, we will continue it to 1 year. So I will talk about the negatives as well. So it did not give an overall survival signal yet, and is MFS a reasonable surrogate? And I think it's a reasonable surrogate. This is where we are heading. Now, if you point specifically to OS, it's going to take decades for us to get that answer in this era. And I think this is a reasonable surrogate that we should use. So 9 times higher pathological complete response, 20% relative reduction in distant metastasis, 19 months longer time to first subsequent therapy, and increased rash was the only side effect. So I wouldn't say only, but one of the side effects. Both primary endpoints were met, 8.9 versus 10%. And what it doesn't answer is what we need to look at. No surgery alone control, but there's a sub-study that's being done with surgery alone. Results are expected in a few years. The same flaw recurs across 30 years. Just as URTC, that is the BOLA trial, never re-included an RT alone or ADT alone arm once RT plus ADT became standard. Proteus builds on an assumed ADT backbone rather than re-isolating it. And I think that's what Professor Clark alluded to earlier as well. Now we are blindly following ADT, and is it good in the long term are we able to exactly substratify patients who really benefit from treatment intensification is the question that we need to answer. A 9-fold increase sounds dramatic, but the absolute PCR minimal residual disease is 8.9%, which leaves more than 91% of people not having reached that endpoint. Again, should we be looking at more intensification to achieve a better pathological complete response? Again, the future will tell. This is where I think studies will target. And survival, maturity, and toxicity, metastasis-free survival, not overall survival, is a mature endpoint so far. And grade 3 and 4 adverse events were higher with apalutamide, 39% versus 31%. So future directions, a planned Proteus sub-study, I already told this, compares apalutamide plus ADT plus surgery versus surgery alone. The first attempt to directly answer the question this talk opened with. Hopefully these results come out and give us a good answer. And head-to-head modality comparison. Again, SPCG is an ongoing RCT randomizing men with locally advanced disease to radical prostatectomy versus primary RT plus ADT. Direct evidence and not cross-trial comparison. Hopefully this gives out answers as well. And we should push treatment intensification further, hopefully to reach that pathological complete response when the patient goes in for surgery. And better patient selection, this is the holy grail. We're all looking at it, Decipher, Oncotype, Artera, all these are going to help us substratify patients so that we choose which patient is going to benefit from intensification, which patient directly goes in for surgery, which patient is a better candidate for RT from day one. So the take home is radiotherapy's 3-year ADT standard took 12 years and 4 landmark RCTs from 1997 to 2009 to build. It was earned and not assumed. We surgeons were faffing about those days. And surgery's parallel neoadjuvant trials did not give the answer that we wanted. Messing was the only study that proved that adding ADT to N1 positive patients did result in overall survival. SWOG S9921 came close, but it was a missed opportunity because it didn't really look at what we wanted. And Proteus reopens this debate, this question, with modern ARPIs and meets both primary endpoints, but still lacks a surgery alone control, echoing the very design gap that has followed this field since 1997. So Raghavan, thank you for this opportunity. Thank you, Professor Clark, for coming over to Chennai.
Thank you, Anand. That's always pleasure hearing you. Any questions for Anand? Sir.
Both of them spoke about the Proteus trial. Basically, I think he showed a curve, Kaplan-Meier curve, which shows that the marginal difference, there's not much of a difference. My question to you is that, should we change our practice adding ARPI or not?
Well, my view is no, not at the moment. I mean, I'll show you some data on what happens when you put the patient on longer-term ADT in relation to bone fractures. And that's just one facet of treatment, leaving aside all the other stuff, you know, the sexual function, the libido, et cetera, et cetera. So I don't think, not for me anyway, that it indicates a change in treatment. Because if you look at the comparator trial, which is the ENZA-RAD trial, which was a very well conducted study in Australia, and compare that with the STAMPEDE data. So STAMPEDE M0 had a very clear outcome. And ENZA-RAD was very disappointing because it didn't. But when you look to the characteristics of those patients in ENZA-RAD, they were much lower risk profile. And in Proteus, the risk profile is quite wide, really. And I suspect that the true effect for the patients is being lost in the noise. There's a whole group of patients who, they do okay no matter what happens. And there are some who don't. And we need to focus on that a little more. That would be my view.
So, can I quickly put on these slides, please? Just to answer this question. So I had this arc of ENZA-RAD trial here that Professor Clark was mentioning. And I think the reason we didn't see that difference was it already had a strong backbone with ADT. And adding RPs to that maybe didn't make that big of a difference. But the surgery didn't have any backbone to start out with. So maybe it might make a difference for surgery. Professor Clark says we may not change practice, but the ground reality, I think, here in this part of the world has already changed. I think Raghavan was the forerunner. I think he started based on the RNEO trial. And now for high risk, locally advanced, we are starting patients on ADT plus RPs. But I think there's a lot of positive thoughts on this trial. But like Professor Noel Clark says, the long-term overall survival has not been proven. So we need to take everything with a pinch of salt.
What Anand mentioned was that we started a project, a cohort study. As it's always the case that randomized studies are a bit difficult in this part of the world. So a cohort study we started somewhere in 2019-20. We used a combination of ADT and an ARPI in a very similar to the design of Proteus. Patients are getting these combination drug around the surgery for 1 year or 18 months. And we have about 234 patients now. And what we have observed is that the necessity for any further treatment beyond that has been about 21%. Only patients required any further treatment at up to 7-year follow-up, and almost 70% of the patients have crossed 5 years of follow-up still. So we published the neoadjuvant data, we published it, but the full data is yet to be published. But there are a lot of downsides. It's non-randomized, it's a cohort study, and that's the best we could do. But what I observed is that in the Indian population, looking at the same PCR and MRD, that is the pathological complete response and minimal residual disease. We found that ADT with abiraterone produced nearly 35% patients had near MRD, less than 5% disease in the RP specimens, compared to apalutamide, which had about such a minimal residual disease was achieved in only 5%. So there was some variability in what we are observing, but I'm putting all of them into a paper and studying it for publication. What I thought is that I'll leave it for another 2 years so that I have almost all of them crossing 5 years of follow-up, so that we have some decent thing to publish. But what we observe is that not only this is my practice, but even Raghunath in Bangalore and RGCA in Delhi are also starting the practice, or are having very similar practice.
Thanks, Raghu. I mean, one of the big problems, I think, with Proteus is that they didn't have a surgery-only arm. And so the biggest series that I was aware of from Memorial Sloan Kettering, which is James Easton's group, published the outcomes from about 370, I think, patients treated, high-risk patients, node positive, treated with radical prostatectomy. And a substantial number of those needed no treatment at all out of 5 years. And the ones that did need treatment or did worse and were the ones that had a high lymph node burden. Now, it would seem a flaw, and I don't know why the Proteus team did this, not to have done a standard of care arm. So when we planned Stampede 3, we said, well, what's the standard of care in the UK? It's observation. But what we know is that, and we've got this from the population data, we're about to publish this, is that when we take patients who've got Gleason 8s and PSAs over 20, it's in excess of 60% are requiring radiotherapy for PSA failure within 5 years. So clearly that group of patients they are the bad actors that we need to get at. And there are a whole group of men who do very well just with a radical prostatectomy, or indeed with radiotherapy.
But having only an ADT arm, not SOC, does it not add strength to the argument that ADT plus RP? So, for instance, this trial, because it had a comparator arm of only ADT and not standard of care, which is just radical prostatectomy, does it not strengthen the argument that RPs are adding benefit?
Not for me, no, because they've not compared them with standard of care. So if you take the Messing trial, which you quoted, it was way, way too underpowered. There were only 100 patients in that randomized 50-50. It got quoted and quoted and quoted inappropriately. So had the team, the Proteus team, which is a very good team, done a radical prostatectomies on just randomized 3 ways, they would have got there. They would have had an answer to this question, and now they haven't. So
they have a subgroup analysis that's happening right now, which is only a radical prostatectomy arm.
Yeah, well, that's the problem with that is there's a bias.
True.
It's not randomized, and no, quite.
Thank you so much.
Can I ask a question, please?
Yeah, please. Yeah.
This is for Dr. Anand. Sir, we see a lot of patients. I work with Dr. Raghavan, so a lot of patients we are starting on abiraterone with ADT, and we do an RP. When the biopsy report comes, we get a good response pathologically. Now I keep asking him the same question. Should I reduce one medicine and just continue ADT alone? Why give both the medicines again for 12 months, 18 months and all? So this to reduce the side effects of the medications. So is there any standard of care that we need to give it for 18 months, 24 months, both the medicines, or we can cut off one medicine and just give ADT alone?
That's a very valid question, and that's something that needs to be answered. For instance, if you have a pathological complete response, which means there's no evidence of tumor, that's a valid question the patient will turn around and ask us. Should I continue it? But are we giving it only for the prostate entity, or are we giving it for the micrometastatic disease that's outside the prostate as well? And the assumption is if it works in the prostate, hopefully it should work for micrometastatic disease outside as well in that time frame. But honestly, we don't have that answer. So it's a valid question. but I think future studies need to answer that.
Okay. Sir.
Thank you so much. I'm going to request Madhav Tiwari. I had a slide for him, but I'm just going to talk about him now. Anyway, Madhav, please come on. Thanks, Anant.
Thank you.
Almost everybody in this room knows Madhav. Madhav is a consultant uro-oncologist in Apollo Cancer Hospital. He was a trainee with us, now a consultant colleague. Does fantastic work in prostates and kidneys. And I've asked him a question: is Relugolix the new ADT? I asked the same question to Professor Clark, and looks like it is a new ADT or acceptable ADT in UK. So are we going to change our practice?
Huh? It's not. But it's not extending. It's working now. Very good evening to everyone who is here today. Thank you, Dr. Raghavan, for giving me this opportunity. Thank you to Professor Clark for being here. It was a pleasure listening to him back in Hyderabad as well as today. Dr. Raghavan asked me to talk about Relugolix and whether this can be the future of ADT. Now, this is not a new drug. This drug has been around for over a decade. Maybe not in India, but it has been around for more than a decade around the world. So why are we having this discussion about ADT in 2026? We already have agonists and antagonists what work very well. We have luprolide, we have degarelix, we have cosrelin. All of these work very well. And especially all the antagonists such as luprolide, they are all very well established. But they do carry some warnings about cardiovascular risk. So when Relugolix came into the picture, this was an oral antagonist, which was deemed to provide all the benefits of degarelix, but at a much convenient way to the patient. So degarelix has done very well. It is an injectable antagonist. It avoids the testosterone surge which was seen in the agonists, but it did carry the injection site pains and monthly visits for the patient. So this is where Relugolix sits in, providing an alternative. So looking at what Relugolix really is, how it works. It blocks the pituitary GnRH receptors, and there is an immediate suppression of LS, FSH, and testosterone. There is no surge, just like degarelix, unlike the agonists. How we started is you give a 360 milligram dose on the first day, then 120 milligrams every day. This can be taken with or without food. It has a very effective half-life of 25 hours. What that means is it starts working very quickly, and when you want it to stop working, especially when you're wanting to use ADT in an intermittent fashion, it washes out really quickly as well. So the HERO trial was a big phase 3 trial, what had around 950 men in it. 622 of those received relugolix and 300 received leuprolide for 48 weeks. They were trying to look at how the testosterone was, the castration rate was. And 96.7% of patients on relugolix sustained the castration rate, as opposed to only 88% with leuprolide. So this was the first trial that demonstrated both non-inferiority as well as superiority of an oral antagonist over agonists. Again, the speed of onset was much quicker. At 4 weeks, 56% of patients on degarelix achieved the castration testosterone by day 4, whereas none of the patients on leuprolide had achieved that. So in essence, it starts to work very quick. But the big advantage was the 54% reduction in MACE risk. So in the relugolix arm, there was only roughly about 3% incidence of MACE, as opposed to 6.2% with leuprolide. However, this was only on a 48-week basis, so we really need long-term data. But still, as we all know, especially in India, where cardiovascular disease is a leading cause of non-cancer deaths, such a medication is highly beneficial for our population. There is another unique advantage to relugolix. Like I said, it starts working quickly, but when you don't want it to work, when you want it to wash out, it washes out quickly due to that 25 hours of half-life. So they looked at patients where they stopped relugolix and how quickly they recover their testosterone. So within 90 days, roughly 50% of men will achieve their baseline testosterone or near normal testosterone. So the testosterone levels after stopping relugolix reverted back to 288, as opposed to only 58 with leuprolide. So all this once daily format, fast on and off kinetics, they really help reduce the side effect burden. So now let's look at relugolix versus degarelix, because degarelix has been around for a long time as well. How do they differ? Not really in any major difference, other than this is a once daily pill as opposed to a monthly injection. In the Indian scenario, we have the cost effectiveness. It is degarelix is somewhere around 15 to 17,000, whereas relugolix is only around 6 to 8,000. Both do better than agonists when it compares to when we look at cardiovascular events. The advantage of relugolix over degarelix is it doesn't need your patient doesn't need to come and see you every month. He can take it at home. The downside with degarelix is if they miss a dose, it is not like a depot. There is no buffer with relugolix. So they're both equally, like I said, equally efficacious. There is no head-to-head randomized trial between the two. Again, they have a distinct advantage over agonists when it comes to cardiovascular risks, and the advantage of relugolix is only limited to it being in the oral format. Now again, there is a use case again for relugolix. This is in patients with who are going to undergo radiotherapy because of the rapid testosterone recovery post-RT. So 52% of short-term relugolix patients in the analysis recovered their testosterone to over 280. So we don't really have any safety data in the RT setting, but we can extrapolate the degarelix data to the relugolix as well. So all of this was seen in the HERO trial. Now, when we combine relugolix with either abiraterone or apalutamide, we again have no safety issues. It must be noted that apalutamide is a PGP CYP3A inducer. So if your patient is getting apalutamide, you either have to give a double dose of relugolix, which is 240 rather than 120. rather than, so you have to give 240 rather than 120. But that effect is not seen with abiraterone. Also, there is a concern. A lot of our patients are already on degarelix. So when I was making this presentation, I looked what would happen if they switch over to relugolix, and nothing happens. The only thing you have to make sure is you start the relugolix on the day your patient is due for the next injection. And the castration levels are seamlessly maintained during the switch. So pros of relugolix: oral once daily, superior castration rates as opposed to agonists, faster onset, faster no testosterone surge, no requirement for the flare protection, cardiovascular safety. Again, this is over agonists, not over degarelix. The advantages over degarelix is only the oral format and reversibility, which in turn leads to fewer complications. Cons, like I said, there is no depot buffer in this. If your patient misses a dose, he has to either take the dose within 12 hours, and then that's okay. If 12 hours has passed, then he has to restart it as soon as possible on the next day. So even though theoretically it's not going to make a big difference, but there is no buffer like you would in a depot. Again, we cannot use it with concurrent oral PGP inhibitors such as erythromycin, amiodarone, verapamil, rifampin. So if you are going to put your patient on to this, you need a thorough evaluation of the medications they are on, because there is significant drug interaction. Now, with certain drugs, I'm going to show a slide later. With certain drugs, it is better to avoid it, but if it is unavoidable, you maintain a 6-hour gap between relugolix and those drugs. So the OPTYX phase 4 study, which was came out this year, had 999 patients. The adherence rate here was 96%. There was no safety signals identified. Most common side effects were anemia and acute MI in 0.3%. And this reinforced that this is a good drug, does not require any intensive monitoring, and can be, this was a critical validation of the oral daily format in routine practice. So who are the ideal candidates in your practice? Patients who have high cardiovascular risk, patients on radiotherapy where you would want to have them recover the testosterone quickly, patients where you're planning intermittent ADT, patients who have phobias about injections, patients who cannot travel all the way to the hospital to get their depots, and again, when you're trying to start them on combination therapy. So these are all the patients where you could use relugolix. So you start with a loading dose of 360 milligrams on day 1. It is advised to confirm castration levels of testosterone and PSA at day 28. You maintain the relugolix with usually with 120 milligrams. But if you put them on apalutamide, you have to give them 240 milligrams. So that is an important point. And you can switch over from the injection on the day when the injection is due. But you have to emphasize to your patient that they have to take it every single day. This is not an injection where it will have a sustained effect. So this is probably the most important side effect slide, what we all must know. We have to avoid relugolix completely if the patient is on oral PGP inhibitors such as erythromycin, clarithromycin, amiodarone or verapamil, because the adverse effect risks are multifold when we use this. So avoid if possible when the patient is on rifampicin, carbamazepine, because it leads to some testosterone escape. If it is unavoidable, then you separate it by 6 hours. You give the relugolix first, and 6 hours later you can give all the other medications. A full review of the cardiac medications is a must when patients are going on relugolix. So I think it is best to get all these patients screened by your cardiologist. So side effects are again similar. Just because it's an oral drug does not mean it won't have side effects. So patients will have hot flush. You have to take care of their bone health. You have to do their metabolic monitoring. So all of those things I'm not going to touch into because of want of time, but exactly like you would take care in with agonists or degarelix, you have to do it with relugolix as well. So there are still limitations and unanswered questions. There is no head-to-head trial with degarelix. The MACE, the cardiovascular benefits that I talked about, we have to understand the HERO trial was not looking at cardiovascular events. That was just another analysis that they did and found it, and it only ran for 48 weeks. So we don't have long-term cardiovascular impact data. Again, this drug has limited long-term oncological data as well. Cost and access, I think in India is not a big deal. It is readily available and it's quite cheap. So prioritize this in high-risk patients who have cardiovascular comorbidities, radiotherapy candidates, and when you're planning intermittent ADT, counsel again about adherence from day one, that this is a daily tablet, screen for drug interactions, and you can easily switch over from injectables as and when you want. Thank you.
Any questions from the floor?
Any questions? Is how many use relugolix or widely used relugolix? Or you're still sticking with fluperlide or whatever? Yeah. Okay. I asked Professor Clark. Apparently, it's widely used in UK as well. Yeah.
So I think from 2012 or 2011, they've been using relugolix in UK.
We've only started using an oral antagonist in any volume recently, and the population figures are going up, and it's regular relugolix really. We use degarelix in the acute presentation of metastatic disease to drop the testosterone immediately, but that we don't use relugolix for that.
Thank you, Madhav. Thank you so much.
Thank you for the three wonderful presentations. Now it's time to honor our speakers. First, I'd like to request Dr. Tirumale Ganesan sir to honor our chief guest of the day and star speaker, Professor Michael Clark.
Okay.
Dr. Raghavan sir to accompany. Thank you. It's coming. Thank you so much, sir. Next, I'd like to request Professor Karunamurthy sir to honor Anantakrishnan sir on the fantastic talk on doublet therapy. Thank you, sir. Raghavan sir. Thank you, sir. I'd like to request Professor Sendilvel sir to honor Dr. Madhav Tiwari following his wonderful talk on relugolix. Thank you. Next.
So we are coming to the last talk. When I invited Professor Clark to come and talk here, one of my requests to him is the last 10 minutes should be inspirational for the next generation to start doing quality work and ask critical questions to themselves. So, and that's a talk I'm looking forward to as well. After that, we'll be having dinner and then we'll disperse from there. Professor Clark.
Thank you, Raghu. If you wouldn't mind, just, yeah, fine. If you wouldn't mind bearing with me while my computer boots up, I had to go and get my mains lead. Schoolboy error. So Raghu asked me to be inspirational here, and so that's quite a daunting task. But it is late on Sunday evening, and so I've put together something which I hope will stimulate you, and particularly at the back, those promising, highly talented, hard-working junior doctors who will ultimately look like this at the front, just to hopefully give you some rules by which to rule your medical life. So we're nearly there. Yeah. Come on. You get an insight into the inner workings of my mind, really, when you see that I start off with a topic and I whittle it down until I've got it. So we're on version 5 of this now, and I hope it's about right. And it's not that one. It is that one. Okay. Don't want to give things away. Right. So I thought I'd entitle this The Importance of Observation, Inquiry, and Innovation in Urology. This is my hospital. The big gold building is where my research team sit, and the big white building across is a molecular biology facility. So I'm going to start with a quiz. Has anybody heard of Maurice Hillman? Died in 2005. Hands up if you have. No. All right. So this is the man who discovered and did all the trials on mumps, hepatitis A and B, chickenpox, meningitis, pneumonia, developing them from the labs through trials, and his National Medal of Science citation. He saved more lives than any other scientist in the 20th century. So, when I think about setting a legacy, if nobody remembers Maurice Hillman, well, what chance do we all stand? So I've got another one for you. Anybody know who this is? He was a research pharmacist who worked at AstraZeneca, about 15 miles from my hospital in Manchester. Anybody heard of Sir James Black? So Sir James Black invented the H2 blocker and the beta blocker. Hugely important discoveries. And so all of the antacids, so as a junior surgical registrar, I would quite commonly do vagotomies, perforated ulcers, all gone. We don't see that now because of this man and the beta blocker, which we all know is such an invaluable drug. So you've got a chance to redeem yourself now. Barry Bloomberg discovered and tested hepatitis surface antigen and the hepatitis B vaccine. So again, a major figure. And it's interesting that whenever I put this series of slides up, nobody's ever heard of them. Everybody puts up Huggins from 1942, but nobody puts up Maurice Hillman. So, 3 rules for success in life. So the older group or personnel in the audience will have heard, I think, of John Paul Getty III. Has anybody at the back heard of John Paul Getty III? No? Ladies, having a discussion. Have you heard of Elon Musk? Yeah, the richest man in the world. So John Paul Getty was the richest man in the world in the 60s. And his 3 rules of success in life: get up early, work hard, strike oil. So most of us get up early, most of us work hard. We haven't always struck oil, but we're hoping that we will. And what about this one? You've heard of Sherlock Holmes, the fictional detective. And one of the great lines in his books is this: you look, but you don't observe. And it's critically important in medicine that you keep that in your mind. And you need to keep this in your mind as well, which is that to be a good surgeon, you must first be a good physician. It's all about observation. It's all about auditing your results. It's all about researching new ideas and not accepting necessarily established dogma, and not necessarily going down the line of just being a surgeon who takes something out, whether it's a kidney, whether it's a prostate, whether it's a testicle, whatever it is. And going back in history, I'm sure you won't have heard of this man. So when I was growing up as a clinician, this is Lord Moynihan of Leeds. And he was a huge figure in the 1930s. And he was the surgeon to the king. He was knighted and then given a lordship, a hereditary peerage. His son is still sitting in the House of Lords today. And you can learn two things from what he said, which is I could teach my butler how to operate. Now, I don't have a butler, and I don't suppose anybody else here has a butler either. So surgeons in those days had a bit more clout. But the key message is that just being a technician doesn't make you a good surgeon. And you need all the people around you, you need to foster those things, and you need to follow those rules, which I've just shown you. And you need to remember that communication, collaboration, and professional respect is absolutely essential. And so if you're going to shout at somebody, remember that you might need them in another 6 months or another 12 months, and actually they're often quite smart. So you've got to remember that. So let's start with a lesson in history. What you see here are two eminent surgeons, Theodore Billroth of Billroth Gastrectomy in 1881. And this picture demonstrates how surgery was taught. It still is a little bit in the modern era, but people would turn up to his operating theatre in and around Bremen, Hamburg, and he would demonstrate operations. And the magic hand of Theodore Billroth would be laid on you, and you sank or swam, both as the patient and as the junior doctor. What you may not be familiar with is Sir Benjamin Brodie, 1832, so somewhat earlier. This is the first account of metastatic prostate cancer in the scientific literature. And this is Brodie's account from Lectures of Diseases in Urinary Organs. Again, he was a very prominent figure, physician to Queen Victoria. And in it, he describes a cirrhosis of the prostate. In other words, it was really hard, really solid, that it produced such pain that massive doses of laudanum would not mitigate the pain. And I picked this out. This is from the University Library in Manchester, and it's signed by Sir Benjamin Brodie. And when I read it, it was really quite striking, because I thought, well, there's not a lot changed since 1832, because once you've switched off the androgens and it fails, this is exactly what happens. So let me just give you some clinical illustrations of how you have to look, you have to observe and not just look. So this is, as you can see, just a plain CT urogram. And what you can see on the left as you look at it is that there's calcification in the base of the bladder. This is a 27-year-old nurse. She'd developed cervical cancer, she'd had radiation, and she was getting up 14 times every night to pass urine, and a similar frequency during the day. Her life was completely miserable. And if you look at the picture on the right, there are two other obvious features, apart from the missing left ureter, of course. One is that the bladder is very small, and the other is that there's a hydronephrosis. So this woman was in trouble in a number of ways. So I looked at this, took a history, and we had a chat, and decided I was going to do a neobladder on her. Just excise the bladder, take the ureters back, reconstruct the bladder, which we did. Absolutely great. But actually, what I had forgotten to do was take account of the fact that she'd had pelvic irradiation. And we transformed her from being a patient debilitated by urinary frequency to one who was almost fecally incontinent. She couldn't get out of the house. Because when you irradiate the pelvis, in those days, in relation to the cervix, well, you lose rectal compliance, the distal ileum gets a hit, and so the transit through the colon was such that she was in real trouble. And it was obvious, really, right at the outset that she was going to be in trouble. I just didn't pay any attention to it. We got her sorted out, but it took about a year, I would say, before she was able to function. I saw her probably about a year and a half ago. She's perfectly well. Her neobladder's still working. She's ever so grateful, and she's still alive, with a very functional bladder, actually. So the first message I would say is be prepared for trouble if you're going to have a career in surgery. Anticipate the problems, use your eyes and ears, do the tests, and think not just about removing a lump or whatever it is, think about what the consequences are. And do that before you start. And you've got to think anatomy, physiology and function, correcting those things, planning for whatever you're doing, an operation, and communication and consent. And pay attention to this, because once you've done the operation, it's very difficult to undo it. And it's better to cancel a patient if you're not sure about what's going on. If you've got a problem, try and work it out, optimize the patient, and then you can think about whether doing an operation is going to be beneficial. And you've got to work out, if the data doesn't exist, as it doesn't for many surgical trials, just what is the benefit of certain outcomes or certain treatments. And I've used this as an example of many that we've done, the importance of auditing outcomes. And Raghu mentioned this earlier, that measuring what you do. So we had 100 cases who had had cardiopulmonary testing formally. This was a fully ethically conducted trial. And what we found using cardiopulmonary testing is that there were a whole group of men here, so we put them on the machine, did various physiological measurements. There were a whole group of men and women who actually died very quickly without having a cystectomy because they were deemed unfit. And so if you're going to do a major operation, whatever that is, you really have to ask the question, is that going to benefit the patient? Or what you do, is that going to put the patient at excessive risk? And the cystectomy is a very morbid operation, where cystectomy is centralized in the UK, certainly in England. The 90-day mortality in centers which are high volume is 8%, just the operation alone. So you have to think about whether you're doing the patient a service by going down the line of surgery rather than thinking about what else is available, like radiotherapy. Now, sticking with cystectomy, I want to demonstrate to you the importance of auditing surgical outcomes. Now, I started as a consultant surgeon at the Christie and Salford Royal in Manchester in 1993. I'd been a senior registrar for a couple of years before that in all those hospitals and had done a lot of surgery. And we decided, Vijay Ramani and I, Vijay's from Bombay, and has been with me probably for about 25, 30 years now, and a terrific surgeon. And we decided that we were going to monitor what the outcomes were by auditing the surgical outcomes for TCC of the bladder, having cystectomy. And what you can see is the eras here. So 1970, 79, 80, 89, 99, 2000, 2005. And here is the mortality, percentage of mortality. I was really shocked when I saw that figure. Gosh, we're killing patients here. And when I looked at all of the other centres around the UK and around Europe, they were all running at about a 14, 15% 30-day mortality, not 90 days. And by changing what we did, optimizing the patients, making sure we did the operation properly in a bloodless field, the anaesthetists were a team that we worked with we optimized patients, we stopped all the fluid shifts during the operation, and the effect, by the time we got to 2005, was that the 30-day mortality was 2.6 and the 60-day mortality was 0.4. And that was done simply by doing the operation, by optimizing the patients, operating on the appropriate patients, and doing the operation to the best possible standard. And I don't mean just the surgeon doing the operation, I mean the anaesthetist and all the support staff looking after the patients post-operatively. So when you then start to move on from auditing your own outcomes, you can then start to challenge certain dogma. And at that time, surgeons of my era, juniors, would go across to the American Urological Association, and we would see Don Skinner, who was just the titan of cystectomy, UCSF, and Urs Studer in Bern. And they would serially say the gold standard for treatment of muscle-invasive bladder cancer is cystectomy. And post-radiation cystectomy is a highly morbid operation. So Vijay and I, with Satish Madnini, who's been a surgeon in Manchester now for probably 15 years, we decided to look at all the cases that had primary cystectomy and all the cases that had radiation and post-radiation salvage. And what you can see, if you look at the 30-day mortality here, is there's not much difference between the radiotherapy cases and the surgical cases. And the only thing we found that was in any way different was the stomal stenosis rate. So I sent this paper to European Urology, and we got 2 favorable reviews, and we got a review from what was obviously Urs Studer. And Urs wrote a 3-page review saying why this was rubbish, we shouldn't publish it. And Francesco Montorsi, the editor of European Urology, rejected the paper. I wrote to Francesco, who I knew, and said, look, Francesco, you can have this paper if you like. This is a landmark paper. There's been nothing like it since 1982. And it just shows that if you're doing these things in volume and you get it right, there's really no difference in the outcome. And to his credit, this was published in European Urology, 2009, and has been quoted repeatedly over the years. So, how do you start with audit and research in medicine? Because when you're a junior, it's really quite a daunting task. People say, well, you should do audit. Well, okay, but how do I do that? You start with an idea. It doesn't matter what that idea is. It can be recurrent urinary tract infections. It can be measuring blood pressure in certain situations. It can be the effect of relugolix on whatever it is. There are loads of questions. But you have to start. And you then got to follow what was a great lesson for me when I was a house officer in London under Grant Williams and Peter Phillip. And Grant Williams, who was a transplant surgeon and a very good one, he said, you know, there are 3 rules of research. Is it new? Is it true? And does it matter? And the more I thought about this over the years, I thought, well, he's actually completely right in 3 steps. So, let's ask the question, what's a clinical trial? Well, clinical trials are research studies in which people help doctors find ways to improve health care. Very simple. Each study tries to answer scientific questions and to find better means of prevention, diagnosis, and treatment. And as surgeons, we're not that good at doing clinical trials. We all say, oh, well, an operation's great, this fixes it, we don't need to do a trial, it's obvious. Well, actually, it's not very obvious in most cases. And you've got to remember that surgeons have always been research trialists. I don't suppose you've heard of James Lind. Anybody heard of Captain Cook, the famous explorer? Well, James Lind was the ship surgeon on Captain Cook's voyage to track the transit of Venus in the Pacific. And he wrote this treatise on scurvy in 1753, trying various things to stop the sailors getting scurvy, which limited how far you could sail. And if you lose half the crew, well, you're in a lot of trouble. And he proved that vitamin C was beneficial. So thereafter, the British Navy issued limes and oranges to their and lemons to their sailors, which is why the Americans to this day call the British sailors limeys, because they used to take limes on board ship. So surgeons do research. That's the key message you keep at the front of your mind. Now, I'm going to show you how this can really influence dramatically how cancer survives. Now, believe it or not, obviously these are two testicles. They're both from different hospital administrators. And when I put this up, sometimes people say, well, there's only one thing missing from that, and that's the other testicle. So one is a teratoma, from the Greek, meaning monstrous, and this one's a seminoma. And this is one of the favorite slides in my collection. This is, in black, the testis cancer survival between 1957 and 1972 at the Christie Hospital, which was the regional cancer centre dealing with all the testis cancer. And you can see that if you had stage 2 disease, you stood a really modest chance of survival at 2 years. If you had stage 4 disease, you really didn't survive beyond 12 months. Now, contrast that with the first MRC trial of combination chemotherapy with cisplatin. And you can see that those stage 2 patients are an absolute mirror image of the stage 2 patients in those treated pre-75. Just a dramatic sea change in how we manage these cases. So young men coming in now, not all of them, but most of them are curable. And that's such an oncological success story, which came about through a clinical trial. And the radiotherapists, and Graham Reed, who was a radiotherapist at the Christie, a senior author, but not all the radiotherapists felt this was a good idea. They wanted to carry on irradiating testis cancer, and that took a bit of a fight. But it took a randomized controlled trial to prove that that was the right thing to do. Now, we've heard a little bit about this. It's another landmark study. There's the Boller study, and I'm showing you the 2002 version. There were several other versions. Boller was a very big character. He was a clinical oncologist from Grenoble in France, big fella, and typically Gallic. And one of his favorite sayings was, science is as noble as art. And he would then put up some kind of medical example of this. But what he did do as the lead investigator for the URTC was, as you've seen, he showed that addition of ADT to radiotherapy worked. But there were questions which needed to be validated, and we're there with Proteus, really, which is that there is a signal in Proteus, no doubt about it, but we need to work out what it is and how we refine it. Now, this is the clinical trial PRO7, MRC PRO7 or NCIC PC3. So it's a joint initiative between Canada and the UK, addressing this question, which, as you said earlier on, does radiotherapy do all the work, or does ADT do all the work, and are they synergistic? And this gives an illustration of the kind of work you have to put in with a conventional trial. So the working party discussion started in November 1996. You get agreement on the first draft outline, takes 6 months to get there. You send the full proposal in by February 1998, and then you get feedback from the funders that takes 4 months. And by the time everything is done, you don't get going until April 99. So that's really quite a prolonged process. And then this was published in 2013. The intergroup randomized study of radiation plus or minus, androgen deprivation plus or minus radiation. And what you can see is that there's no doubt that the hormone therapy plus radiotherapy was better than hormone therapy alone. And when you look at the prostate cancer specific survival, again, it's obvious. So that really transformed what everybody did. So back to our 3 rules of research. Is it new? Well, yes, that was new, and it completely changed practice. And I think it's also true to say, is it true? Yes, it was true. Does it matter? It completely changed the landscape of managing M0 prostate cancer. But to innovate and take things further on, because I've shown you the timescale of that trial, which was very long, and then you've got to recruit the patients, and then you've got to wait long enough So again, back to this question of research, an innovative trial design. And you start with an idea, which is exactly what we did. And the question raised was, can we improve the outcomes using new treatments in combination in high-risk prostate cancer? And this came on the back of the knowledge that docetaxel was an effective agent, and there were various others on the market. So how does an idea like that come about? Well, you have a meeting of urologists, clinical oncologists, and statisticians, which took place in York in Northern England. And what you're looking at here is a very youthful Max Palmer on your left. Max is head of the clinical trials unit at UCL, and just alongside him was an even more youthful Matt Sides. Matt Sides is professor of statistics now, an absolutely outstanding pair of statisticians. And Max proposed this novel design, which was a multi-arm, multi-stage trial to look at outcomes. And it had never been done before. And so that was the first big idea. We said, okay, we're going to think about how we do this. So we then meet as a gang of clinicians. That's Nick James, Malcolm Mason, who's professor in Cardiff, me, and David Durnley, head of GU radiotherapy at the Royal Marsden and recently retired. And we came up with this flexible trial design. And as with many circumstances, when you come up with an innovative and completely novel design like this, you'll get people say, whoa, hang on a minute, that's never going to work. But it did, and I'll show you how it did. Because this was in about 2021, where we'd had 16,500 men join the trial, 3,000 site staff across the country. The Guardian newspaper reported it as transformational. The International Statistical Society said it was the best trial, bar none, non-cancer and other cancer. And last year, we won the national prize, beating the COVID recovery trial as the most influential trial. So if you've got a good idea, stick up for it. Don't give up. And you'll always get people who say, oh, hang on, this is no good. But you've got to follow your beliefs, as long as they're sensible. So this is where we are in 2021 and 2023, and we closed out Stampede as Stampede 1, and we've carried on with Stampede 2. So I'm just going to show you at the back, largely. Oh, hang on. Yeah, we got that. I think I've hidden a slide somewhere. Does that come up? Yeah. So this, Nick and I wrote this article for European Urology to coincide with the 20-year anniversary of Stampede, highlighting the importance of platform trials. And you can see on the left a conventional pattern, which is you've got different agents or interventions, T1, T2, T3, T4. They're going to a phase 2 trial, which is a smaller number trial, and then they work or they don't work. And then you've got to design another trial. If it works, you've got to design a phase 3 study, not a small undertaking. So for each arm of these trials, it takes 15 years, which is way too long. Whereas if you start with a multi-arm, multi-stage trial, you keep the control arm all the way through, and you run the various treatments with different intervals, dropping them out if they're not effective, and adding in new agents to test. So the whole trial infrastructure is not reinvented. And that's exemplified really by the graph on the right. So what you can see with this blue line here is how long it took us to get up to 120 centers, nearly 5 years. When we put in the new agents, abiraterone, M1RT, and so on, practice-changing trials, it took us 3 months to get up to speed again. So we didn't have to reinvent the infrastructure of the trial. And everybody got involved with it. All the clinicians got involved with it. They got stuck in. They randomized the patients. And in our MDTs, it was just a default position. We get a patient with high-risk M0 or M1 disease, you say, Stampede trial. That's it. So we'd see the patient in the clinic. And remarkably, we had very few failures for consenting. So you can see the scale of this. These are MAMS trials. This is from 2022, I think, or 2020. And this is the paradigm now for planning a trial. And when you look at the impact that trials like Stampede have had, 16,000 participants, 5 changes in standard of care, better survival in the long run, and there are many other things. So back to our 3 rules of research. Is it new? Well, it definitely was. Is it true? Yep. Does it matter? Yes, it does. And so I'm going to show you another test. Has anybody heard of this man? Sir Peter Medawar? Anybody done transplantation? Do you know who invented all the immunotherapy? Worked it all out? Sir Peter Medawar. And he was an immunologist, a clinician immunologist. But the important thing for all of you at the back is that this statement, which is brilliant, I think. I cannot give any scientist of any age better advice than this. The intensity of the conviction that a hypothesis is true has no bearing on whether it is true or not. So it's important to bear that in mind, because you have to work out the difference between a fact and a factoid. So what's a fact? Dictionary definition, something which is known. It's established. It's like a mathematical axiom. What's a factoid? This was a term coined by the author Norman Mailer. Something which, if repeated loudly enough and often enough, comes to be believed as true. And unfortunately, we have so much of this in medicine. Now, I would encourage you to read this paper. It's an outstanding paper. This is the natural selection of bad science, and it will give you perhaps an indication of what happens when you have repeated poor quality papers driving practice. So what they did, Smaldino and McElrath, who were 2 statisticians, they looked at all the papers published in psychiatry from 1955 through to 2015. And they examined the quality of those papers, and they examined the overall direction of treatment in psychiatry. And what you can see when you look at the power of these studies, the power should be up here. So Stampede, metformin, we had a hazard ratio of 0.8. They're all underpowered, badly designed, poorly powered, and they haven't changed since 1955. Yet, they're occupying the space in the literature. And the clinicians are reading them, and they're drawing conclusions, and they draw repeated conclusions. So if you look at the evolution of effort, so let's say we take this study here, which might say, okay, this is beneficial, we need to change practice. Has that trial ever been repeated to validate it? The answer is no. So when you look at the replications, there are very few replications of these studies, and the whole lot gets driven along and become established as practice. It's a little bit like Buxton's Law. Yet the evidential base for doing that just doesn't exist. So surely that's not happening in urology at the moment. I can't believe it. This paper came out only the other week. We're not being recorded, are we? One of the worst papers I've seen in European urology for many a year. This was terrible. And I'll tell you why. So the title, 3477 patients, prospective IC registers of focal therapy mainly. Oh, no, it's all right. I think Hashamid knows what I think of his trial. And this was, it was sent out on social media. The BBC picked it up. It just went completely viral. And what they said was, well, we've got a 10-year follow-up of 3,000, nearly 500 patients between 2004 to 2024. And you can use it to treat high-risk cases. And the 10-year cancer-specific mortality, 0.13%. Fantastic, isn't it? Why doesn't everybody? The secret of everlasting life is to have a focal therapy treatment. So there's the 10-year all-cause mortality. They started to make comparisons against radiotherapy and surgery, when actually what they should have done was make comparisons against active surveillance, and particularly the PROTECT trial, which had exactly the same result for the active surveillance patients, but without any additional treatment except for further down the line. So let's just unpick this a little bit. We haven't got too long to do it, but the methodology, a non-randomized case series with an inevitable selection bias. Focal therapy is not suitable for many cases of T2 prostate cancer. We know that. No independent validation cohort. Labeling of intermediate risk patients as high risk. And they were explicit about this in the discussion. An inappropriate comparator, surgery, radiotherapy, rather than active surveillance. So that's the methods, and that list could be a lot longer, believe me. Misrepresentation of the results. The median follow-up of this cohort, ostensibly of 3,000 patients, 3,500 patients, was 3.3 years. Of these, 1,118 had a 5-year follow-up, and only 173 had 10-year follow-up. So how does that equate with 3,500 patients followed for 10 years, which was the headline message in the abstract? And then, to add the cherry on the cake, speculative comments in the discussion. I've just picked out one. Of the patients who required radical treatment, we estimated only a small proportion had an imperative indication for radical treatment. Many patients with recurrence after the initial focal ablative session would have been suitable for further focal ablation. There was no evidence in any of the paper at all to substantiate that claim, yet it was in bold, and I've no idea how that got past the reviewers at European Urology, and I think there will be a backlash over it. So, let me just move into basic science. What you'll all have noticed is when you're at medical school, you think the textbooks are where the evidence is. And sometimes it is, but mostly it's 10 or 15 years out of date. And you have to get stuck in to addressing certain questions. And as I said earlier on, challenging certain dogma, like radical prostatectomy for high-risk localized disease is no good. That's just unproven, as far as I can see. And so within Stampede, and this is just an example of how we've done it, we've got other research programs going on, we have triangulated the whole lot. So we've got the informatics on all the data in the secure data haven in London. We've got the tissue going into UCL, and that's headed by Gert Attard, medical oncologist. Oops. We've got the big team, biomedical imaging. That's our team with Ashwin Sasteva and me. We've got about 12,000 scans on our servers, and Nick James and the Royal Marsden team looking at radiation dosimetry. And this is funded by a variety of sources, and we feed people through. You have to build a platform for this. So this is our group, some of the alumni. We've got a fantastically talented technical scientist, and Mick Brown, the associate scientist, and they form a basis for all of the stuff that you need to do for the molecular imaging and so on. Ashwin Sasteva, academic consultant with me, enormously talented. I'll come back to that in a minute. And then you've got research fellows, Alex Hoyle and Adnan Ali. They changed world practice for our Stampede RMH. Craig Jones published a paper in Analytical Oncology about fractures. Omar, we've heard about, and two of our very bright boys here, Struan Gray and Cameron Alexander. And they're all engaged looking at different aspects of the Stampede trial and cross-correlating that with real-world data. So back to our questions. Is it new? Is it true? Does it matter? Well, is it new? Yes, Stampede was new. Is it true? Well, it's true in the Stampede trial, but is it true in the real world? And that's where we want to have a look. So age and comorbidity, trial patients are younger, ethnic subtypes, we had very small numbers of Afro-Caribbeans, Asians, and so on. Population demographics, the poorer patients tended not to be in the trial in the same way, and we all know they live longer, they live shorter. The long-term effects of treatment and cancer biology. And just before I come off this slide, I just want to emphasize this, because when you look at the length of follow-up of these patients. With an academic trial, you can follow patients for extended periods. With a pharma trial, Arasens, for example, they have data cutoffs at short intervals. And the reason they do that is they only have a certain amount of time to cash in on their patent. So long-term data comes from academic studies. And we're now in a position to link all this with a number of data banks, particularly using the National Prostate Cancer Audit. And I'll show you briefly just what an influence that can be when you look at fractures. Back to, should we be giving ADT to all these patients? So this is published in Cancer Epidemiology. Matt Parry is just been appointed as consultant. He will probably come to Manchester, I think. And so this is how it works. So focus on the table here, and you'll see a whole load of numbers here. Now, each one of these is a hospital code. So when a patient comes into a hospital, there's always a code if they have something done. You can't get the GP stuff, but you can get, so if they have a fracture, however it is, spinal fracture, hip, knee, whatever, it's recorded. And then we map that with hospital episode statistics, looking at how patients present to A&E. And this is the cumulative data. So you can see here, we've got big numbers here, 40,000, 2,500, 13,704. So this is, substantial data. And this is a real surprise to me, because these are patients with metastatic disease treated with ADT, because that was the standard of care pretty much. And what you can see is a clinical fracture occurring within 5 years in 40% of men. None of these had bone protection. What we also saw here, these are the M0 patients, high risk, treated with radiotherapy and ADT. The clinical fracture rate was 16% in that group of men at 5 years. Now, that's what happens when you put patients on ADT and you don't give them bone protection. And we've known that for years, but not done anything about it. And we've gone on to look at, and this is Craig Jones' work, looking at the effect of zoledronic acid in STAMPEDE, linking STAMPEDE to HES. I won't go through the consort diagram, but these are all the arms in STAMPEDE. And we had arms that had zoledronic acid in, which is a bisphosphonate which slows down bone resorption. And what we could see in the M1 cohort is for those patients who had zoledronic acid, they had a clear reduction in their fracture rate. It reduced the fractures by about 30%. And that's in a fit population, so probably better in the older population. And back then, to address the question of relugolix, because when you read the paper on relugolix, this is the HERO trial, be critical about it. Just dissect it out, and you'll find that there are big holes about it, and there are certain statements which don't necessarily stack up, but have been repeated as a marketing process. In other words, is it a fact or is it a factoid? And pharma companies will generate factoids by over-publishing work sometimes from the studies. Don't get me wrong, I think that they do a fantastic job on the whole, but you've got to remember that there's big money at stake when they're publishing and marketing their data. So this is one of the projects that Omar Al-Taji was doing. What we know is that major adverse cardiac events occur with ADT. And so we wanted to look at this to see whether the addition of docetaxel or abiraterone and enzalutamide added anything to the risk. And Omar had done a 24,000 patient systematic review of all the trials, which suggested that there was a doubling in the cardiovascular risk rate, that's MACE risk, in patients having doublet therapy. So we've got over 6,000 patients here, 2,400 roughly M0, and roughly 4,000 M1. And a MACE is an MI, a stroke, cardiovascular death, a revascularization procedure. Now, what was interesting is this, that when we actually followed the patients and allowed for competing risk, in other words, men who had abiraterone lived longer, so their chance of getting a fracture was greater. So it looked worse in the trials, and actually when we analyzed it from all the individual patient data linked to HES, the ADT was the problem. It didn't make any difference adding in abiraterone or adding in enzalutamide. The MACE rate for M0 was about 16%, and for M1s about 12%. So bear that in mind when you're thinking about giving a patient ADT. Now, my final two slides, back to this. Is it new? Well, yep, it's new. Is it true? We think it is. Does it matter? These are two papers which have just come out. One is ours, which is the MPCA data here, which is population data, 45,000 men between 2015 and 2022 with primary metastatic disease, and this is SEER data here, up to 2019. And when you look at the survival of these men, 50 to 59, 70 to 79, these data are pretty comparable. And that is that the reduction in mortality out at 10 years is about 10% down. And that's a real triumph. And that's come about from asking a question, planning a trial, monitoring that, matching it with real-world data. So, you have to discriminate between a fact and a factoid, which you need to think about.
Thank you so much, Professor Clark. Have any questions? Yeah.
Very enlightening talk, Professor Clark. Of all this, the paradigm shift we are seeing now is patients themselves are coming up with their own idea of the treatment. See, at the end of the day, we need to have a good discussion with the patient. But many times, the scientific evidence is against what the patient wants. In such a scenario, and with upcoming radiopharmaceuticals, a year back we were sitting in a discussion on theranostics where there were a lot of nuclear medicine physicists there. They were telling that they could give equal results and outcomes even for a localized prostate without surgery. So when that is put in front of a patient, it's automatically the patient is going to be pulled towards that. As urologist, we should see this as a competition, or is it the right way forward? How to go about this, and in this context of research also.
How much do they get paid for treating it? So this problem was evident in Germany. And when you click on PSMA administering sites, up come probably about 10 or 15 centers around Germany, which will freely treat you for about 25,000 euro. In Cologne, where Axel Heidenreich is, they had a nuclear medicine physician who was treating primary prostate cancer in just the same way. And he was stopped
and they promise equal results.
Well, they clearly aren't. It's just rubbish. He was taken to court. He was instructed to stop, otherwise he'd be struck off because it was inappropriate treatment. And that's the way to deal with it. You really have to stop that, because the nuclear medicine physicians, they don't really understand the disease. They understand the dosimetry, they understand the ligands and so on and so forth. But do any of them see patients in the clinic? Have any of them managed a prostate cancer patient? So I would say you really need to strongly push back on that. Get the medical associations on it. If necessary, get the courts on it. You've got to stamp that out. Otherwise, it's just the Wild West.
Okay. So it lies more with the administrators now to say no to theranostics and more towards unindicated.
Yeah.
Yeah, actually, as urologists, we have started seeing medical oncologists and nuclear medicine physicians as competitors rather than our collaborators, because a lot of the caseloads are now moving towards them. it's a real life story, I think. How is it in your country?
So get writing. Get out on the social media. Meet fire with fire. You cannot allow that to carry on.
Okay.
So with that, we'll bring a closer to the session. Thank you so much, Professor Clark. As I said at the beginning, Professor Clark was one of the inspiration for us to do what I do, at least a little bit of what he is doing, about 1/1,000,000th. Nonetheless, the inspiration, I hope, percolates down to the backbench and the next generation. And my request to Professor Clark was the last talk should be that inspiration for you all. Always ask the critical question, is it true? Is it correct? Is it what we want to do? And do not develop yourself as surgical technicians, but be developing yourself as surgical scientists. Thank you so much.
Thank you. Thanks.
It's time for dinner, so all of us can move on and
Sir.